sit this far away from the pub.
Welcome everybody. I'm Rod Shane. I'm Chair of NHS Cheshire and Merseyside Integrated Care Board. Delighted to see members of the public here today at our September board meeting of NHS Cheshire and Merseyside. I should have put a caveat right at the beginning. I had my flu jab 2 days ago and I can feel it coming through now. So hopefully I'll last the day. But apologies for that stumble at the beginning. So I'm going to kick off by asking the directors around the table to introduce themselves. I'm going to go with Alison on my left first.
Thank you. Hi, I'm Alison Lee. I'm Director for Knowsley, part of NHS Cheshire and Merseyside.
Good morning, Mark Palethorpe. I'm the NHS Place Director for St Helens and also the Exec Director in the Council for Adults, Children's and Public Health.
Good morning, Councillor Paul Cummins, Cabinet Member for Sefton Metropolitan Borough Council and Partner Member for Local Government on the ICB.
Good morning everyone, my name is Erica Morris, I'm a non-exec director.
Morning everyone, I'm John Llewellyn, I'm the Chief Digital and Information Officer.
Good morning, Ian Ashworth, Director of Population Health.
Good morning, I'm Fiona Lemons, I'm Associate Medical Director.
Good morning, I'm Neil Large, Non-Exec Director.
Good morning, I'm Rowan Pritchard-Jones, the Medical Director for Cheshire and Merseyside.
Hi everyone, my name's Claire Wilson, I'm the Finance Director for the ICB.
Graham Irwin, Chief Executive of the ICB.
Good morning, Tony Foy, Non-Exec Director.
Good morning, I'm Claire Watson, I'm the Assistant Chief Executive at the ICB.
Good morning, my name is Anthony Middleton, I'm the Director of Performance and Planning.
Morning, I'm Naomi Rankin, I'm Primary Care Partner Member.
Good morning, I'm Joe Rafferty, I'm Chief Executive at Merseycare and Lead Chief Executive for the Community Mental Health and Learning Disability Collaborative as a partner member.
Good morning, I'm Chris Douglas, Director of Nursing and Care at the ICB.
Morning, my name's Hilary Garrett, I'm a Non-Executive Director.
Good morning all, my name's Adam Irvin, I'm a Primary Care Partner Member at the ICB.
Good morning, I'm Moran, Chief Executive of Mersey and West Lancashire Teaching Hospitals and a Partner Member.
Good morning, I'm Louise Barry, I'm Chief Exec of Health Watch Cheshire, but here for the 9 Health Watch across Cheshire and Merseyside.
Good morning, Alison Cullen, I'm representative for Voluntary Community, Faith and Social Enterprise sector on the ICB.
Good morning, I'm Chris Moser, I'm the Chief People Officer.
Thank you. We've got 2 apologies this morning, Warren Escadale and Steve Broomhead. Otherwise, we're all here and we're quorate. Any declarations of interest that have not been made already that are relevant to the agenda items receiving today? No, thank you. Can I turn to the minutes of the previous meeting, which were in July, and seek any corrections, matters arising that not on the agenda? So I'm going to take that as we are agreeing the minutes. Thank you. Can I turn to the board action log? In front of you, I'm going to take any updates or corrections. Ian?
I was just wondering, Chair, there's just a couple of updates from my name next to it on the action log. So last meeting we had an update on the population health and health inequalities in there, and we also had the anti-racism framework as well, so we were wondering if that would be comfortable for the board to take it off the action log as completed.
Okay. People comfortable with that? Thank you. And Claire?
Yeah, thank you. I've got a few here actually. Action 29, I think probably that can be, we've superseded that by, we're going to bring the Primary Care Access Recovery Plan next time. So I think hopefully we can agree to close that action and bring that in November. I think action 40, we'll take that through the System Primary Care Committee, if that's okay, because that's about GPs and carers.
Okay.
I think Action 44 is closed, again superseded by the Primary Care Access Recovery Plan coming in November, and we did bring an update in May or June. And I think there are a couple of others, 45 and 47, which are linked all around the Integrated Performance Report, Anthony, which will be coming in November.
Yeah, and the same could be said of 55, Chairman, as well.
Thank you.
So we'll go through some of those, if that's okay, and close them down.
Okay.
Sorry, Chair, if I may. And Action 56 has also been completed. We used one of the regular meetings of all chief executives across the patch to do a substantial financial strategy session, including financial recovery and savings targets.
Thank you. John?
Thanks, Raj. Action 54 followed a discussion around digital inclusion, and in our toolkit we've got a series of measures that address the risk of leaving service users, citizens unable to access services, primarily based around a risk, an impact assessment document, and that process and our toolkit's been referenced in the National Digital Inclusion Framework, which was launched yesterday as an exemplar. So our approach is outlined in the toolkit and how we'll manage that risk.
Thank you, John. Well, thank you for those updates. It is important to keep the action log as up to date as possible. We'll revise the action log in light of what's been said this morning and redistribute it to board members. People happy to go on? I'll go on to the board decision log. Any comments? No. So I'll take that as that's there for noting. Thank you. Just a couple of announcements from me. Firstly is to express on behalf of the board and NHS Cheshire and Merseyside our sincerest thoughts, prayers and condolences to the families of the victims of the Lucy Letby case. I'm sure that many of us around, if not all of us around this table, feel immensely deeply a sense of shame, a sense of how could that happen, a sense of what are we going to do about stopping it from happening again into the future. Countess of Chester and Lucy Letby case is on our patch, and we will be unrelenting in our approach at supporting the families, supporting the Countess of Chester and supporting the NHS to do so much better. Aligned with this is the launch of the Thirlwell inquiry. That is the public inquiry into the matters around the Letby case. We will be ensuring that we play our full part in that, not just to the letter of the law, but within the spirit of the intention of that inquiry. And a little bit related to this, I guess, is an assurance that I wanted to give to all our organisations, to the staff and to members of the public. That we are going through now a routine of ensuring that all people in senior positions undertake assessments as and when they get appointed, and then on a regular basis. That ensures that their experiences, their qualifications and their track records match what's expected of public officers. That's called a fit and proper persons test. So on those two matters, I'll close and I'll pass over to our Chief Exec.
Thank you, Chair. Chair, I'm also going to start with just recognising the absolute significant event associated with the conclusion of the trial of Lucy Letby, to remind people that this is going to continue to occupy the thoughts and have consequences for all of those people involved, not least because you will have seen in the media that an application for an appeal has been lodged, and the Crown Prosecution have also stated their intention to prosecute one case again where no verdict was found. We also know the police investigations remain live into a range of other cases where we know that the individual cared for babies. So this is going to continue. Now, what I would also say to you is I will be meeting the solicitor who's been appointed to support Lady Justice Thirlwell next week. We have received a copy of the draft terms of reference, but we have received those in confidence. Now, I think that's a good sign that they want to speak to us and other parties about whether or not they have the terms of reference right, and they want to listen to us in that regard. But unfortunately, I'm not allowed to share those with the board or with the public in the public domain. But the board should know that we are in receipt of the draft terms of reference. We have already taken some steps to prepare ourselves for the inquiry. Namely those include identifying our head of emergency planning, preparedness and response as a single point of contact for the organisation to liaise with the inquiry. We will set up a small oversight group to coordinate our responses, and we have already taken steps to make sure that we have secured historic records and access to portions of old IT systems where there will be a number of emails and records stored from predecessor bodies to this ICB. So we'll keep you posted in what the demands the inquiry places on us, and we'll keep you informed in terms of how that progresses. It is also the case that I've asked Matthew, as our Associate Director for Corporate Affairs, to secure legal representation for the ICB to participate in the inquiry, because for our routine legal matters, we actually use the same firm as solicitors as the Countess of Chester Hospital, and for the sake of the inquiry, the lawyers need to effectively have distance between one another, and they can't represent more than one party in the same inquiry. We'll keep the board posted as that progresses. It won't go unnoticed, and I'm drawing this to the board's attention on too many occasions now, but industrial action continues. And as you know before, I've said we absolutely respect the right of our staff to participate in legitimate action, but we're now getting to the point where I think the service is becoming weary of having to deal with this. I will talk about this in the annual general meeting, but the convergence of strike action between different staff groups, the impact that that is having on frontline care, the number of patients whose appointments are either not being arranged or cancelled as a result of this, is now having significant impact on many of the targets that we're trying to hit and many of the aspects of healthcare that we are trying to improve. What I would say is my thanks to all of the staff within our hospitals and within the ICB and within primary care who continue to manage the consequence of this. And don't just think of this as our frontline staff. You have to think of all of the people in our booking departments, all of the people in our admin departments, the people who arrange appointments, who have to phone patients up. The burden of this is now becoming really very significant. In the last, since we last met, because of information that came to light within the education sector within the UK, this so-called rack plank issue hit the news in a big style. And what I would say to you is this is something that has affected healthcare premises. We have known about this for a significant period of time. We have been managing this for a significant period of time. The place that is most affected on our patch is is Leighton Hospital in Cheshire. And again, if you look at the pictures that are appearing on the telly, you will see the similarity between the construction of that hospital with other hospitals such as Kings Lynn, Frimley Park. You know, they were all built to the same building note at the same point in time. They all have a very similar style. And because the NHS has been managing this for some considerable period of time, not only is a significant amount of capital being spent to keep those services within those buildings safe, we also know that 9 of those hospitals had been promoted to be a first priority within the new hospital build programme. We'll therefore arrange for colleagues from Mid-Cheshire Hospitals NHS Trust to come to the board in November to present us with a progress report on the development of the business case to replace the hospital at Leighton. I'm not going to highlight every item in the report, but I also wanted to highlight the matter of right care, right person. Again, you will have seen significant presence in news and media online about what the police will or will not be prepared to do from the 1st of October onwards in terms of certain calls to the police. This is something that, as with any change, until it's actually happened, you cannot predict every unintended consequence of this. But what I can assure the board is we are working very closely with both of our police forces. We are working very closely in the liaison with our 2 mental health trusts in the police forces, and that's been coordinated from the ICB's perspective by Simon Banks, who is our place director from the Wirral. So additional investments are going in. Those additional investments have been in alternatives for crisis care, alternative places of safety, expanded Section 136 suites, all of which are not open yet. But actually the real issue here is the relationship that we have with the police to make sure that we sensibly don't overburden them to stop them from doing their core roles, but that also we do not leave any vulnerable person without a service and a response. So really important that I highlighted to you the work that is going on in that area. There are a number of other things that I have disclosed within the report this time, which I'm really happy to deal with through questions, Chair.
Thank you. Can I take any questions? Neil? Steve?
Thank you, Graham. Can you hear me? Is that working? Thank you. On the industrial action, I suppose my concern is that recognising the disruption it causes and the stresses and strains on staff, there's a patient at the end of each of those numbers. And we hear nationally there's 1 million appointments cancelled. And you say you'll come back at the next board meeting with further information. What I'd like to understand is how many outpatient and inpatient procedures are being cancelled in Cheshire and Mersey by each provider, split between elective and non-elective? And how do we know, and how do trusts assure themselves that there's no harm to patients?
May I, Chair?
Please. Yep.
I'm going to reframe your question, Neil. And the question is not about how many appointments have been cancelled. And what we need to do is we need to take a typical strike day and we need to compare that to a typical operating day in a previous week. And we need to look at the loss of activity between those 2 dates. Because we have notice that the strikes are going to take place, a number of patients are not actually booked on those days. So just to measure cancellations wouldn't be the right measure. We have to measure the actual loss of activity that comes as a result of that. Now, in terms of managing the risk, what we know is that each of our providers effectively categorise their patients, and they categorise their patients between those patients that are very urgent, those patients who should have their procedure within a month, and those patients who should have their procedure within the next window of time. And then after that, we then treat in turn. So once you've gone through the highest category of clinical need, other patients are treated in turn. And so it's really important that those patients with the highest clinical risk are rebooked quickly. And again, each of our hospital trusts has an assurance process to look very carefully that says, are those patients with the highest clinical need being rebooked?
So we are meeting with the medical directors at the minute daily on the lead up to strike action and beyond. We've got a clear process in there to escalate if they are unable to treat patients, so that there is a mutual aid offer. If we need to move patients in order to make sure we keep them safe. It's also an opportunity to share some best practice about where you should go looking for some of the concerns. For example, we spent a lot of time thinking about multidisciplinary team meetings, because actually, if those don't go ahead, you risk delaying someone's cancer care if a decision isn't made because it falls on strike days. And that learning from some of our trusts has allowed all of our medical directors to go away and ask the question, how are we, it's not just about what should be happening on the day, but how are we reorganising, for example, cancer team meetings around strike days in order to manage it. So we have communities of best practice, the ability to elevate, the offer of mutual aid that allows that system working to further mitigate in the best way that we can. Thank you.
Okay, so is there some way then you can articulate the scale and extent of what's happening in the strikes for us? So that I don't understand what the scale and extent in Cheshire and Merseyside.
Yes, we intend to do so, and I'm going to talk some more about that in the AGM later today.
Okay, thank you. And I've got one other question which is less important. It's just on the Lewis building, the rental. Why are we taking out an agreement on the Cunard building? Why are we taking out a lease on that when we've got the Lewis building?
Yep, please. So it is our stated strategy to move out of as many properties as we can that we are commercially renting to reduce the overheads and the running costs. And a part of that process is to relocate as many of our place teams alongside local authority colleagues. So the lease of the Cunard building is to move the place-based team into Liverpool, and we have an intention that at the next break point in the lease for the Lewis building, we will leave the Lewis building and we will stop using that as a premise.
Thank you. Can I go to Steve? And then I'll go to Joe.
Right care, right person. Thanks for raising that too, Graham. Of course, it is a partnership response and partnership effort involving the NHS, the voluntary sector, and of course local authorities. I'm aware that there's some money being made available to the ICB. I think you mentioned it for investment. Will any of that money be delegated to place, because there's no additional resource for local government, and it puts enormous pressure on social workers, emergency response teams, as well as others? Will some of the money reach place, Graham, rather than just going to the areas that you mentioned when you gave the update?
Graham?
This is another one of these issues where the Department of Health have wanted to control this centrally, and the Department of Health are signing off item by item bids. So effectively, the capital investment for a new Section 136 suite You know, the investment in a new service to have additional mental health staff in an ambulance car that can respond to situations and initiatives, and the parameters within which bids could be submitted are the areas in which we have bid. So there has been no funding come apart from that we've bid for against criteria.
Just to say I'm disappointed about that, because it's an integrated response which is required at place-based. Perhaps we could consider going back and see whether we can work up some bids for the 9 places.
Each of the places have been involved in the construction of those bids. I think the issue that you're really highlighting here is they are largely health service related bids, not integrated bids. And as I say, you know, that's been a product of the criteria in which the Department of Health have set this out.
Joe?
Can I just chip in on this one? Although it's a different question. Steve's right. One of the most significant workforce-related issues is approved mental health professionals, so AMPs, social workers. And I mean, if we don't address that issue somehow, accepting that it's not in the current bailiwick of how the money's going to come out, the sort of physical facilities will help, but they won't help entirely. So it's a reasonable point. I wanted to talk about, or just quickly make reference to item 11, Graham, which you didn't specifically cover health referrals into treatment services, so people with addictions into treatment services. It's interesting, but nowhere in the 6 bullet points is there any reference to the importance of trauma-informed care. So probably somewhere between 80 and 90% of people with addictions have a dual diagnosis of mental illness. Dame Carol Black recently visited us, who's the government advisor on this, and was very clear that addiction services that are trauma-informed, in other words, they ask the question, why are you addicted, not just how do we treat the symptoms of your addiction, tend to have much, much, much higher levels of recovery. And I just wonder if I could ask Ian, maybe, could we do a piece to review our addiction services to see how many really fulfill that trauma-informed piece? Because from my own experience of running these services, when they get dissociated from mental health services, it's really problematic to get the sort of real recovery rate driven properly.
Thanks, Joe. Ian?
Thanks, Joe. So I think on that main bit, it was about, there was a bit of scrutiny around actually seeing a significant reduction in the number of referrals coming from health-related backgrounds, and you're asking for some assurance about what we were doing around that specifically. Now, actually, it's a bit of a challenge, really, because during that period they were looking at was a time when local authority public health grants were being reduced, as were a lot of substance misuse services scaled back, which you can imagine has a knock-on effect on the number of referrals and capacity coming through. However, they have been building back through the new drug strategy, through the combat and drugs partnerships, and I think it's about trying to make those reconnections again. Absolutely agree about the dual diagnosis, something we were wrestling in my previous post in Cheshire West, so perhaps it's an action we can take that away with the other directors of public health and see what good practice is being done and work with you on that.
I'm happy to help if you want.
Thanks, Ian. Any further questions? No. If I could just return to right care, right person, Graham, just and ask, given that we understand the department has set some clear criterion for the allocation of fundings, I think what we've heard today is an ambition to be more integrated in our approach. If through you, then could we return to this in due course and understand what we can do as an integrated system, perhaps through each place on this question?
Yes.
Okay, thank you. Are we happy to move on? Rowan, I think you're leading the next agenda item.
Thank you, Chair. I'm delighted that Diane Green has come to join us today, and I'll let Diane introduce herself in just a moment. Colleagues here at Board will recall the significant investment that we have made into our entire programme of work that comes under intelligence into action. Our health intelligence is a rich source of understanding the challenges that the population we serve are living with. But it cannot simply be a tool that allows us to commentate on how difficult that is. It has to be a tool that brings about some real action, that makes changes to our patients' lives, and rightly so. We are an integrated care system, and that means the partnership working, not just with perhaps primary care or secondary care, but most importantly, that health and care partnership that reaches into our local authorities, is something that we are here to make work really well. I was delighted that we put a bid in for a modest grant, health innovation grant, that allowed us to set up a fuel poverty piece. Something like 13% of people across the UK are living in fuel poverty, which is hugely challenging. And knowing that we as a health system are also living with the challenge around resources, colleagues here will have heard me say repeatedly that we must make the very best use of the resources we have, find those in greatest need to make the greatest difference. And so what we've done with this project is to start to cross-reference our understanding of those living in fuel poverty or with deprivation and fuel poverty, and also with some of the most severe health conditions that will be negatively affected by their living conditions, particularly things like COPD, chronic lung disease, and asthma. We have started to make that work, and it is colleagues like Diane who have led that on the front line that I really wanted to invite to share the story of what that has meant to the patients she cares for, and for her as a very experienced community respiratory nurse doing this for a number of years. So Diane, on behalf of Board, the warmest of welcomes. Thank you for coming to join us, and I'd like you to share this story, please.
Well, thanks for inviting me, Rowan. Obviously, I'm nervous, and I will have to make sure that I don't cry because I'm so passionate about this. I am employed by Mersey and West Lancashire Teaching Hospital, and I am the lead COPD nurse in St Helens. This project has really opened my eyes to being a nurse. It is truly proactive working now. We have started with working with Cypher through GraphNet to identify patients who are in the 10% lowest deprivation, diagnosed with COPD, living in poverty. As community nurses, we've known patients have lived in poverty. And actually, we've optimised patients, we've, done their inhaler technique, we've tried to prevent them from coming in and out of hospital, but we've never really looked at what poverty means and what it looks like to the patients. Through GraphNet, using AI, we've been able to identify these patients and target them in a different way that we've ever been able to do before, and this is truly integrated, holistic nursing care. We use the Johns Hopkins algorithm to drill down quintile 1 for deprivation and quintile 1 for poverty, but also those that have had the highest admissions in the last 12 months and diagnosed with COPD. But even through that drill through for that information, as nurses, at the click of a button, we had all the information that we needed for those patients truly to optimise them. Whether they'd been immunised, whether they were still smokers, whether they were optimised on their treatment, what quintile of poverty they were actually living in, and that made us pick them to prioritise first. And here are some of the outcomes that we've achieved, and we've only been starting since February, and it was a bit late for winter, but it was called, the Affordable Warmth, but we decided to change the name in St Helens to the Warm Homes for Lungs project. And as you can see from those figures, which I won't go through them all, but 100% of patients have received referrals to the Affordable Warmth team, and that actually says 85, but our latest figures are 106, and we've still achieved 100%. They've all been referred to the Affordable Warmth team. It says there that £32,500 of household funds, which is government money that the patient should have had, we now have given out £41,500 to patients just to help them with their household bills. And that mightn't sound a lot to us, but £500 per patient, which they received and will receive again this winter, has made a massive difference to keeping them warm. Out of those patients, obviously we've mentioned that they've been referred to the Affordable Warmth team, but they've all been optimised, they've all received visits from the nurses. We've increased our referrals to pulmonary rehab, we've increased our referrals to telehealth, which is just, again, something else to help try and keep patients out of hospital. And this truly, to me, is joined up working, because we've been working and meeting regularly with our partners to discuss what is available for our patients, what has changed, what other facilities we can offer them. And obviously we've been working in partnership with St Helens Care, with Merseyside, with CHCP, and now we've just brought in Taurus, which is our local social housing, to try and help them to help us to prioritise patients who are in need. The key to it all has been our care coordinator, who has managed to keep all of the patients together, but also to telephone the patients and find out what their needs are, and to gain consent to refer them to all of these places. Stacey's here today. She's managed somehow to get the patients to open up to her, to tell them that how they were really struggling financially. And this is a story about one of our patients, Paul. He was living in St Helens with his wife and his daughter with mental health. Now, we'd been to see this man before, but he'd never told us that he was sleeping on the couch and his daughter was having to sleep with his wife with mental health, because he was too proud to tell us that actually the spare bedroom had a hole in the floor and all upstairs was covered in mould. So through Stacey, he told her he had mould everywhere. We referred him to the Affordable Warmth team. This man has now had the hole in the floor fixed, new windows. He's had the whole house replastered. All the mould is gone. He's been given £500. And now he's sleeping in his own bed again. This man and his wife have told us we've transformed their lives. And we've nursed this man for years. And now, the difference that we've made to his life, because we asked him, was he cold? Could he afford his heating? I've been a nurse since 1986, and we've never transformed patients' lives like this. It's just unbelievable what we've achieved. You know, as a community nurse, we're very privileged. We go into patients' houses and we see them and we optimise them. We never really go upstairs unless they're dying and they're in bed. They never tell us that they can't afford a light bulb upstairs. They never tell us that they're really struggling to pay the bills. And the difference that we have made through looking at this through different eyes, and this truly is holistic work. This man had had 3 hospital admissions before we intervened. Since then, he's not been in hospital once. His house is warm. He can afford to put his heating on. He's got no mould. He's had his house insulated. He's had new windows. And the difference that is made to these patients' lives is truly unbelievable. And this is why I get so passionate about what we've achieved for these patients. Another story is a man. This man actually was a retired engineer. He had his own pension, but with rising house bills, his property had become cold. He told Stacey that he had to choose between putting his oxygen on or heating his house. His wife felt isolated. He had a dual diagnosis of COPD and interstitial lung disease, so he was on 8 litres of oxygen a day. He couldn't really get out of his house because His scooter wouldn't come out the door and he needed a bespoke ramp, but he couldn't afford it because he couldn't afford his heating. His house wasn't insulated, it was cold. Through referring him to the Affordable Warmth team, obviously we optimise. We do what we do every day, and I'm proud of my team for what they achieve. But this man now has had a new boiler. He's had his house insulated. His wife has been referred to the Carers Society, and she no longer feels isolated. He's received £500 of household funds to help him. We've given him a pulse oximeter so he can manage his hypoxia. We've given him a fan to try, and my nurses pay for these fans out their own money, but they help them to be less breathless. The symptom of the air on the face helps patients to feel that they're getting oxygen when sometimes they don't need it. And, you know, because it's not funded, we pay for it out of our own money, but we know the evidence is there and the difference that it makes to patients. His house has been insulated. We've sorted out where he was storing his oxygen because he was storing it in the porch, and that is obviously a fire hazard, so we've removed that and arranged for that to be moved in other places. There's so many things that we've done for this man and other people. You know, in St Helens, it mightn't seem a lot, but we've replaced 4 boilers, which means that 4 people aren't going to bed at night thinking, is my boiler going to make it through the night because I can't afford to replace it? Am I going to be cold? You know, he had to choose between having his oxygen or keeping warm. And we know when we give patients oxygen, and especially if they have prepayment cards, we don't realise that actually they have to pay for that oxygen up front. So that matters to their financial bills. That matters when we prescribe oxygen, that they're going home and they're thinking, have I got enough money to charge my meter to pay for this? They don't get their money for their oxygen till 3 months later. And that's 3 months of hardship for these patients. Working with the Affordable Warmth team, working with the social prescribers who truly are, they're all angels, it really has transformed the life of patients. And here's just some of the things that our patients have said to us. They've made my life easier. There's so many quotes. They've helped me think about not having to think about my bills as much. Before, I was not using my heating, but it's better now. I can keep warm. And that's just a few of the things that they've said. Some patients were really sceptical when we contacted them. You know, it's cold calling. Hi, I'm Stacey. I'm phoning up to see whether you're cold. You know, are you struggling with your bills? Some of the patients thought this was too good to be true. You know, and if the lessons learned, I think we'd probably publicised it a bit more before we did it because we had to do a lot of work around reassuring the patients. We've developed a leaflet now to give out to patients, which we should have really, in hindsight, had ready before to say, you know, this is true, holistic, joined-up working. This is not just about making sure that your health is okay, but how can we prevent you going into hospital, the internal stresses that we all deal with every day due to our financial strains. You know, some patients I now know, you look downstairs and everything seems fine, but actually they're going upstairs in the dark because they can't afford a light bulb. They're grateful because we ask them to fill in a questionnaire and we give them a Costa coffee voucher for doing it. But actually they're grateful to us because we just give them £500. And this money that they should have had, you know, and this is something I'm so passionate about now, that every service should be offering this. We've already decided through the AI that we're going to start targeting other areas, and we've targeted another 411 patients that we will now start looking at. These patients have got interstitial lung disease, bronchiectasis, brittle asthma. They're all at risk of hospital admission, and a lot of them are too proud to tell us that they're cold. And this is some of the things that my nurses have said. It's quite wordy, but I'll just pull out a few little things that they've said. One nurse said, boost team morale and increased our job satisfaction. Found it heartwarming and humbling that patients express so much gratitude to us. I felt empowered to help with their financial worries. privileged position to see how beneficial this is to patients. And, you know, I mentioned before, I've been a nurse since 1986, but this is truly holistic working. You know, we're taught to educate our patients about their health. We're taught to help them. You know, I've talked to some of my new nurses, you know. I'm an old nurse and, you know, so I've asked them, what is true nursing training like now? Are you taught about asking patients, are they cold? Are you taught about, you know, referring them on to make sure that they've got everything they need? And every one of my new nurses said no. And they all said that this has really transformed how they nurse. We're going to struggle because we've only got funding from our care coordinator, 6 months from the Innovation Agency. You know, we do need more money to help to support this. We do need to target, and this should become mainstream. This should be a way that we look at our patients to identify them, to target them, to keep them warm. Keeping them warm, and especially if they have long-term conditions, will truly keep them out of hospital. We've proved that, and just with one patient. But I could sit here all day telling you about all of the patients that we've helped so far. And I just wanted to tell you that story because it's just, this is real, true, proactive and not reactive care. Thank you.
I'm not sure how you can follow that. Dan, you won't know this. You're the first person to get a round of applause at the board. And
Sorry, I've turned into tiny tears.
And I'm sure, you know, people felt the passion, the emotion, the care, the professionalism. And wow, what a tonic. When I started the meeting off saying I was ashamed of a nurse, to see and hear you and your colleagues and the fantastic work that you're doing.
Thank you for inviting me. I just hope that, you know, this will help in a small way to change how we work as nurses and doctors, and to think about, you know, when a patient's in a hospital in a clean bed with, you know, the clean towels, but when they go home, the reality is that most of them are living in deprivation. And as community nurses, we go into crack dens, we go into houses where they've got damp roofs hanging off, you know, ceilings with, you know, holes in them. And this is how we tackle it. This is how we identify these patients, and this is how we make a difference. I know patients go into hospital because they're cold and they're hungry. You know, we now link in with the food banks, and we're giving them vouchers as well. So it is something that, you know, we are really passionate about, and I do hope that this really does make a difference.
Thank you, Diane. You make the papers and the numbers that are sat in front of us here today come to life.
Yeah. Thank you.
I'm going to take some questions, just a couple. Alison, then Chris, and then Ian.
Thank you, thanks so much. I think something similar is happening within each of the places. So in Warrington and Halton, we have a very similar piece of work where we've got the voluntary sector embedded within the hospital discharge team. I know they do something in Sefton, and at the moment something's been set up in Cheshire West. So I think it's really important that we all share that learning, because where there's elements where you said, had we done this a little bit earlier, and if you think, well, if we'd started sharing some of that information, I was really surprised about the number of people who were discharged from hospital into cold homes, into going into just lying on the sofa because they don't want to go upstairs, and you think they're going to end up back in hospital a week later. So we have a whole team of link workers in the voluntary sector supporting those patients. And I think that element of that information where you've got around COPD, I think there's something that we could learn from that as well, in terms of which cohorts of patients should be prioritised. But I think really importantly what you said at the end is that's a 6-month piece of work. Ours has been a 2-year piece of work that I've done across all of the 9 places around hospital discharge and support once being discharged. It's all non-recurrent funding, it is all short funding. So I think this really does need to be embedded within the work of hospital discharge, and investment is needed to reduce readmissions, to admission avoidance. It's a really important piece of work, and it is just how, you know, how passionate you are about it, feel exactly the same, and that's what we as a sector see on a daily basis. So, yeah, around people's health. So, thank you.
Thanks, Alison.
And fully agree with everything you've said there.
Thank you.
Thanks.
Good, really great points. Chris?
Yeah, thanks Diane, thanks for sharing it. And as a fellow community nurse, I've felt your compassion coming through there. So what I wanted to say is it would be really interesting to hear you come along maybe to the Director of Nurse Forum, which covers both acute hospital, community and social care, because I think there's perhaps something we can do around educating our nurses within other sectors to maybe aid you in having the questions asked previous to you, because obviously you've got a small team there, and I think it's probably about creating a movement here. So I'll probably get in touch with you about coming along, and then we can begin that discussion and probably start that social movement that we need. So thank you.
Yeah, absolutely. I really appreciate that. Thank you.
Thanks, Chris. Ian?
Brilliant. Thank you. You bring it to life better than any report can ever do so, and the passion that just comes over. In many ways, it's really quite proud to see some of that in action, even though it's really sad that we need it. So, a couple of just last week, the healthcare just informed the rest of the board. The healthcare partnership held a housing and health workshop with our many local authority partners, political leaders around there. We had Liverpool City region there and colleagues across Cheshire and Warrington, hearing about new local energy demonstrator projects running across Cheshire and Merseyside and Warrington in particular as well. And there's loads for us to be building on in different places. We were able to share actually that case study with the healthcare partnership, along with work from Warrington and Knowsley as well. So it's really good to see some of that being delivered in each of our nine places. Some of the findings from the workshop that came out would just reinforce it being a priority around housing for our healthcare partnership, and we agreed to take some of that forward as a strategic relationship. You mentioned tourists, but other housing associations and registered social landlords. And I think it just goes to show what that integrated work can do with the local authority teams and the community sector in tackling really challenging situations. So really welcome the update today. Thank you.
Yeah, and interestingly, just that first study, this was a social housing property. And so through the Affordable Warmth team, they managed to connect with tourists and prioritise that work. So that work was all completed within an 8-week period. So it just shows you, with the support of us, what can be achieved.
Thank you. And finally, Naomi. I'll bring Anne in as well.
I just wanted to say thank you. I think you've really brought to light this project. This is truly an innovative, proactive and preventative project that will not just have an impact on patients' health, but has an impact on the entire family. Just to say, one of my patients was part of this project, and his grandchildren will now visit him at home because he has no mould. So this impacted an entire family and is impacting entire communities, and we see the benefit from that. I think what I would like to see is, how do we then take that further across the entire ICB? How do we put that not just in secondary care or in community care, but so much of preventative medicine happens in general practice. You know, our practice nurses are going out to do the chronic disease management reviews. They also see this. So how do we highlight those patients who are most at need and prevent them having the 3 hospital admissions or the oxygen at home? I think this could be so much bigger than focusing on patients who are already at that level of need. Let's take it a step further down the line and let's prevent that level.
Yeah. Great points, Naomi. And finally, Anne.
Yeah, I'm not asking a question, I'm just addressing a comment. So I've never failed to be amazed at what wonderful staff we have at Mersey and West Lancashire Teaching Hospitals, and you are a fabulous example of that, and I just wanted to say thank you, well done, and please keep up the good work.
Thanks, Anne. Right, given what we've just heard from Diane, the passion, the bravery of coming here, because it's, and Stacey, put your hand up. Who's Stacey? Is there any other members of the team here? Well, fantastic, well done. You have thrown us a challenge, and Alison threw that challenge, and Naomi's thrown that challenge. As we've heard something great today in a particular part of our sub-region, We know from Alison that's some good similar work going somewhere else. But here we sit today thinking, why isn't it happening everywhere? And we've seen the dramatic impacts on families, on the individuals, on staff, but also on some of the other associated factors that we are here today talking about, like the winter plan. So challenge, Graham never likes me to do this. And I think the board could ask of the executive team and the partnerships, in particular place directors, to hear in November how we're spreading this at pace, at scale. Rowan, if you've got the answer already, let's go for it. Otherwise.
Well, so we've now got the board that is set up to manage our entire intelligence into action programs, that is working through how the intelligence we have can be lined up with all the different assets that we already have at place, whether that's social prescribing, what community assets are at work, where there might be gaps that we need to fill, but how we can use this intelligence to make the biggest impact across our patients. So that entire programme of work, supported with the right governance, is now in play, and with Ian as well from the population health side, that is precisely what we are here to do. This was almost our proof of concept with this small grant, but it allows us now to demonstrate the impact and to take it across the whole of our system. That is what I'm expecting, and it's what we're working towards.
Fantastic, Rowan. So let's understand at November's board how much progress we're making and what impact we're making. I know that's a tough ask, but let's hear that. Okay, let's go. Thank you, Diane and Stacey, and I didn't hear the Kathy, thank you for. You're very welcome to stay for the rest of the meeting, but if you need to go, that's fine. Chris, can we go to your report, please?
Yes, thank you, Raj. So the paper highlights some of the current issues that may have an impact on quality and safety within the system. And you'll see within the paper it refers to sort of rapid quality review meetings that have taken place since the board last met. So you may remember in July it was agreed that due to a lack of progress and improvement at pace, that a rapid quality review would be established in line with the National Quality Board guidance for East Cheshire Hospital Trust. So, and that was relating to the standard hospital mortality index performance. And we had a discussion and a discussion of the work that's taken place to date. So it was agreed that further work would be required by the Trust around prevention of deterioration. And it was around the early identification of deterioration and the prompt response and support that was required. So you'll see within the paper the focus of the work that the Trust is now doing in respect of how we recognise patients' deterioration sooner and how we respond. So the subgroup's been established within the organisation now to progress the improvement work. And we've got a further rapid quality review meeting tomorrow to look at some of the further data there and listen to the improvement that's taken place to date. So at the end of my report, I'll invite Rowan if he wants to comment on the work, because Rowan's been chairing the rapid quality review. Also during August, we held a system-wide rapid quality review, which had a focus on choking and aspiration. And you'll see within the report it references the learning disability mortality reviews, or otherwise known as LEADER, that are completed for the local area. And we've had a number of reviews that have taken place which identified death by choking or aspiration, and that has also come through the coronial process as well. So we undertook this rapid quality review as a system. We had a considerable turnout. It was held virtually. Our system partners and agencies joined. A number of us around the table were also present. And the next steps following that rapid quality review is to consider how that data is shared and how we capture and triangulate with a view to preventing any further deaths from choking or aspiration. And so there's further work, and we propose to present that to a future Quality and Performance Committee. And the final rapid quality review, the board's aware that Cheshire and Wirral Partnership have had rapid quality review in place for the last 8 months in respect of a number of indicators around quality and performance. We had a meeting in August with Cheshire and Wirral Partnership, and as a group we accepted the improvements that had been made throughout the rapid quality review process, and we put forward that we would recommend that we step down the rapid quality review and move back to the business as usual through our place teams, however within ensuring that the continual progress is made. I've referenced the SEND agenda there, which explains the governance process and oversight for our SEND, which is for special educational needs and disabilities, which is everybody's business, and we have a statutory responsibility for this as an ICB. We do have a number of our systems that have written statement of action. Currently there are 2. And we've also can expect imminent inspections under the new framework. To date, we've only had one of our local authorities that has been expected under the new framework, and we are working with the rest of the country to look at the lessons learned through the framework process. You'll see within the paper it highlights the focus of the areas that the inspection follows. And finally, I just want to draw the board's attention to the progress that's been made on the all-age continuing healthcare review. You'll see within there, it's a complex review that's happening over a large complex system. We're still focusing around the performance and the quality and ensuring that the performance is achieved. However, you'll see within the report, within the system, we are not achieving the 80% threshold of the decision to be made within 28 days of the checklist being completed. So we're working extremely closely with our place associate directors to ensure that this target is improved. We are working with all members of the system to ensure that the review is completed and that we develop a system for all age continuing healthcare that meets the needs of our populations. So those are the points I wanted to highlight, Chair, and I'll open it up for any questions. Thank you.
Thank you, Chris. Any questions or comments? Neil, Steve, and Joe, and Hilary, and Tony. Yeah. Neil.
Okay, thank you. Just a few questions for me on the East Cheshire. The shimmy score's currently still running at 17. Are we satisfied from the work so far that that shimmy score, the methodology for scoring it is correct, and therefore the excess deaths of 17 or 100 is real? And if it's 17 and 100, how many excess deaths a year are they? Because that's a benchmark. I suppose my other question is then, in terms of the board's ability going forward, what lessons learned are there for the board in managing this shimmy, and do they have the skills and the capacity to, once we get to the bottom of this, is it the data, is it the systems, to actually manage this effectively? And are other lessons learned for the system?
Yeah. Thank you, Neil. So the first rapid quality review we've had, where I brought to bear some of the systems that we've used at Mersey and West Lancs that have helped us understand difficult situations, showed that the rate of in-hospital deaths is a bit higher, but not completely off the charts. It's when you add in the 30 days post-discharge that we are seeing this significant difference. Even within the hospital walls, though, I've identified a series of areas that they should bring some focus to. And they've gone away from that rapid quality review with a very clear direction from me around focused actions, particularly around hydration, identifying early deterioration, escalating that, the way their intensive care unit is working with colleagues on the wards, and some approaches to the nursing way of preventing deterioration in the first place. The expectation with the next rapid quality review, which is tomorrow, is that that comes back with all the detail that I expect for us to be able to be assured that what they're doing in the hospital will have the right outcome. The second stream of work is what is happening out of the hospital with deaths that are happening there. In particular, I'm interrogating the methodology, because if indeed the trust is getting patients home to their preferred place to die because that is their expected outcome, but they're not coding that as palliative, then indeed they're doing the right thing, but we're capturing it in the wrong way. I have already made contact with colleagues in another part of England who can bring an independent peer-led review at an academy of colleges level. What I mean by that is it the College of Medicine that we need, emergency medicine, is it intensive care? And they've got the ability, and they are just completing the proposal for me, that if we are struggling particularly with resources, capacity and capability to understand what is happening out of the hospital, that I've got a solution that can come in and undertake a series of structured judgment reviews, meet with the medical examiners and properly get behind that. I will know more when we meet with the Trust for this second quality review tomorrow, and I will expect to bring that back to the board, but I've got the next steps already planned out meanwhile so that this moves at real pace, because that's what those patients deserve.
Okay, so it could still be methodology?
It could be. I am remaining curious until I have certainty. And then we'll make sure we solve the right problem in the right way.
And the excess deaths of 17 per 100, how many deaths?
So it's not quite, that's not entirely what 117 necessarily means. Again, it's some of the methodology behind that. In terms of what their real excess deaths have been, that's why Shimmy already is being discussed as having some serious concerns to it as to precisely the way it works. I won't necessarily get into the full detail of that here, but I will be bringing back to board all of the detail that we would expect for the assurance as to what we are achieving in there. And as I say, even in between boards, I've got those steps planned out so that we continue to move at pace.
Okay, so you're confident you've got the resources to get on top of it?
I've certainly found all the right people to step forward and help us and support that trust to get it right. Yes, indeed.
Thank you.
You asked a further question, Neil, about the board. I meet now with the chair on a monthly basis, single agenda item, which is the quality question. And the board has just recently instigated a well-led review, externally undertaken, so we'll hear some news from that. And Rowan and Chris had highlighted work that needed to be done about their ability to continually improve and that capacity around that. And the chair is well cited on that and gave me the appropriate assurances around the board. Steve?
Just on the area reviews, I mean, Warrington, as it says in the report, is the only one that's actually had and completed the review so far. There's interesting experience. It's quite clear there's cultural differences with the approach the CQC and Ofsted, and it was all rather new. And of course, these are ungraded reports. It's a commentary rather than any grades, not like Ofsted, which is outstanding good, requires improvement, or inadequate, the gradings. But we got a lot out of it, Raj, actually, and it's really good for continuous improvement, and certainly Warrington for this area, more than willing to share best practice.
Thank you. I must say, Steve, if I could make I most certainly would benefit from a greater understanding of our role and our part in supporting the standards that are required, that are articulated in the SEN reviews. Not now, but at some future date. Good, thank you. Can I bring in Joe?
Just a question to Chris and Rowan, I suppose, about the benefits of having an ICB. It's easy as a provider, I suppose, to look down your own silo and solve your own problem. But it strikes me that here you've got issues of potentially hydration, you've got choking and swallowing issues and so on, and then you lead into SEND, which we may think is unrelated, but those people in SEND often graduate sadly into the learning disability system. So there's a way here to look across all of these issues and see what are the major connecting issues, and it would be interesting just to know how all of these reports are assessed for key common themes.
I wondered, Chris, if we could surface the conversation that we've had recently about issues and trends and that triangulation.
Yeah, and I think, Joe, within, if you see the rapid quality review that's been done as a system, is probably an area where we've been able to look at the learning across the system and how we can prevent similar serious incidents from happening again. So I think that is some of the benefits of how we can work as a system moving forward.
And I've asked Chris to think about how is this board on a periodic basis, I'm not sure how frequent that is, understands the various different issues that are arising from quality and safety as a system, so that we can see those trends and understand how we can better answer your question about what is the ICB going to do about it. I think I've got Hilary next.
Thanks, Chris. Great report. A couple of questions. Choking aspirations, a serious incidents, great, that's being picked up, a rapid quality review. Is there an alert gone out? Because I'm just thinking that, I mean, you've not had this quality review going for some time. It's in its infancy. But if we can save another death quite quickly, it's around how can we alert the system to the national guidelines that are out there while this review is going on. So that's number one. If we can save one more life in the next month, that would be great. So that's the first thing. I think the second thing is connectivity of SEND. I think we've got the major risk here around another review, and I suppose I'm seeking assurance about, are we really cognizant of the risks to the individual children with SEND or adults with SEND, and particularly those that have not had their annual health checks or those that are sitting on our general waiting list. Are we alert to that and picking them out? And what can we do as a board to ensure that we're paying attention to that? And then I think thirdly, continuing healthcare, it's great to see there's a great programme there, and I noticed in our finance report the amount of financial challenges we've got around that as well. And how many people who have not had an assessment are still waiting in hospital beds? And are we discharging them to assess them? Because the difference here to an individual, if they're staying in hospital for longer than they should do, that could be all the difference between losing their home and their livelihood and going into the home. And I think this is about a bit of the triangulation, an example of the triangulation that we may need to do in that regard. And the point was raised by Joe earlier. Some of those are comments, Chris, but it's a really good report that's made me think. Thank you.
Okay, if I can just respond, Raj. So there was a national patient safety alert. However, with an alert that's been produced a number of years ago, people implement the findings from the alert, but it's about the sustainability and maintaining that. And I think that's something that we wanted to do through the rapid quality review process. I think particularly as well when individuals are having packages of care, whether that be in a nursing home or residential home setting. I think one of the particular serious incidents happened to around having one-to-one supervision and the importance of continual reassessment for that. So I think that was the main focus, to ensure that we revisit any alerts that have come through in respect of that, so that we can prevent serious incidents and death from happening. In respect of all-age continuing healthcare, I spent the morning with the continuing healthcare team in St Helens this week, and listening to the team and the integrated team on their approach to this and how patients are discharged to assess, and how they do that within either their own home with support from community nurses or within a residential or nursing home setting. So they they do discharge to assess, and that takes place within their environment, whether that be home or nursing home. But I think what we need to do is ensure that we hit the performance of making sure that from the decision support tool completion, that the assessment for all age continuing healthcare is met within the 28 days, and then that we regular review. So that most important thing is about the quality of the package of care, but also from a financial point of view, that we are getting the most appropriate package of care, but we're not losing any financial issues in there.
Thank you, Chris. Can I go to Tony?
Thanks, Chair. To a degree, I'm only echoing what's previously been said, particularly by Steve and Joe there, about the benefits of partnership working. Looking particularly at your reference to SEND, the inspection framework is a challenging one now because it looks at local area partnerships. But I think what I'm hearing so far is, and what we're going to hear more about later today, is the value of working in partnership as being the model of operation. So I'd like to see in future particular reference made to the board about areas where partnership working is strong and areas where partnership working needs to develop, so that we make sure that we don't lose this important impetus that partnership working brings. So I'd welcome to hear more about that at Quality and Performance Committee, but also at the board.
Thank you. And I think there's the partnership as well with the parent or the carer is in there. And we have the first of our parent-carer forums, which we have set up in the next 2 weeks, where we're meeting parents and carers from individuals who are identified as having special educational needs and disabilities. So that has been set up, so I'll be able to share that through the Quality and Performance Committee, because clearly the parent and carer is a huge part of the partnership. Thank you.
Chris. Paul?
That one. Chris has just answered part of my question, which was going to be about parent carers and how this links to them. And Tony's question, I want to support his comments, because the SEND inspections take place at a local authority place level, and it is very much the responsibility of local partnership. I welcome the involvement of the ICB in the SEND agenda. I really want to see, though, how there is added value because of the ICB is involved in this, and how it links to the partnerships. I've been chairing the SEND Continuous Improvement Board in Sefton for the past couple of years, since we got a poor inspection, and as I said, I do welcome the involvement, but I want to see what that added value is across the sub-region. I'm sure that there must be, but I want to see that in action, and also the how the links with parent carers develop as well.
Thank you, Paul. So I'm going to move us on to the recommendations. But what we've heard, recommendations to note the content of the report, really good report. Thank you, Chris. Generated a lot of debate and discussion about East Cheshire. And we know we're going to return to that through the Quality Committee and back to the board. But I just want to pick out SEND. A lot of discussion and debate about the partnerships that are required to enable us to improve on that SEND agenda. Paul's challenge about the ICB, I think we shouldn't forget that each place is the ICB as well. So we have place people that are part of the ICBs working alongside our colleagues in each place. But let's understand, Chris, through you, in future, how that progression is happening, and do we have a variation across the across Cheshire and Merseyside that we think we could do something about. And finally, just the ask articulated about help the board understand through a periodic report how we can triangulate and look at the key issues and trends that are emerging across the region on quality. So if you could come back with perhaps a discussion paper on how that could be done. Thank you. Anthony, if you could lead us on quality and performance update report, please.
Thank you, Chairman. So we've got the reports here, and a number of the issues that are contained within the report are also picked up in the previous safety report, or indeed the committee report, which Tony will report on next. But I'll pick up some of the salient headlines and probably triangulate with some of the conversation that's just took place around the safety paper. So if we look at how the urgent care system is functioning from a physical health perspective, one could describe it as a period of stability over the past few months now. I wouldn't interpret stability as optimum, but what I would say is that, you know, traditionally around this period of the year, we do see a level of stability, less variation occurring. And indeed, there has been some staged improvements in terms of a reduction in the non-criteria to reside, the number of over 14-day length of stay. And indeed, during that period, in a planned way, some of the acute sector has been able to reduce some of its escalation beds. But what we see is still an uptick in admissions, and we still see an uptick in terms of the occupancy. So it's still a very heated physical system, and as we say, this is summer. We of course got the paper further on in terms of winter, but I guess coming back to some of those discussions really, and well, that's all well and good, you know, that describes the situation, but what are we doing about it, and how does the ICB, both at place and across Cheshire and Mersey, add value? Well, one of the things that we do see is that we do have the ability to look across that broad landscape and see the variation in delivery. Whether it be D2A models that exist as in the area that Chris described may not exist in another system, and that's part of what we're able to see quite readily. And the most recent piece of work I would also exemplify is the work we're doing with NWAS at the moment, looking at the front door and conveyance levels that we see across the Cheshire and Mersey patch, and there is a significant variation between conveyance rates in one part of the system to another. Traditionally, the way we've approached that is by looking at what types of alternative to conveyance are there, but we've never really understood the throughput and the accessibility and the use of those services, particularly from ambulance crews. But we have now got an insight into developing data that provides us with the access, the number of times that the crews attempted to access those services, whether they got through, whether or not there was a clinical judgment, or whether or not they still had to convey. And we're using that information and we'll be sharing with place to try and address the issues that exist. I use that by way of an example, but that probably leads into, you know, we are very conscious that there is an enormous amount of work going on around urgent care improvement within providers and across place. But we probably don't have the necessary governance in terms of pulling that together at the Cheshire and Mersey level. So from October, we have established an urgent care improvement group which runs through the Transformation Committee and will be chaired by an ex-medical director. And thanks to Anne for releasing Kate's time to support us with that. So that will be established in October. That will be the way of providing that overarching governance from what already exists at place level. The intention is that will cover all sectors and all places. And one of the things that we've heard a number of times within this setting is that we have a lot of focus and availability of information around physical health, but some of the other parts of the system, primary care, mental health, etc., just do not feature strongly in this report, and we recognise that. And I'll come on to talk about some of that development at the end of this report. But one of the things that we've been discussing, certainly with the mental health providers, is that most recently there's been a huge level of focus because of some long-staying patients within A&E settings that have mental health needs. And that's the bit we have real visibility on. We see that because it comes through in terms of our daily reporting. And on a daily basis, we are understanding some of the challenges that exist within mental health and community providers. But we are working with them to understand how we can improve that visibility. So it doesn't just appear in these board reports, but it appears in everybody's radar. You know, Joe will often quote, and quite rightly, that, you know, if we look at the bed pressures that exist within the mental health providers, it's facing very similar challenges to those of physical health beds, in that there's around 18 to 20% of patients that require ongoing care in a different setting. And we would go much further than that, even just in the conversation this morning, that we need to have eyes on the number of patients that are in community services awaiting access to mental health bed provision. So we're working in that arena to get visibility, to drive the improvement approaches. If I turn to planned care, we can look and we can see that in terms of the long wait target, we are still ahead of our plan, although the variation against that plan is reducing, but we are still ahead. We still have a degree of confidence in the delivery of that over the course of this year. As the discussion mentioned earlier, it is significantly impacted by industrial action. But if we look at the overall level of activities that are taking place this year, it is still higher than the previous year, which is just a huge credit to the sector that is having to deal with the disruption that causes, the rebooking, the rescheduling, and that continual drive to increase throughput and volumes, notwithstanding that at the end of each and every one of those numbers, as we've heard before, there is a patient, a family, a friend that is affected by all of that change. And it's fair to say that when we look across to some areas of our improvement, we can see real benefits in terms of the focus that we have on improving access to diagnostics, but we're faring less well on some of the improvements and transformation approaches that we may well be doing, such as patient-initiated follow-ups. And some of that will be down to a lot of people are trying to keep the plate spinning, or the wheels turning on delivery, and at times it's pushing out the transformative capacity. In terms of cancer, I think if you look at the bottom of page 8, we can see how some of that access to diagnostics is also paying off in that, as well as that continual drive to improve productivity and numbers. And we can actually see that the backlog is reducing on that. We are ahead of plan, and our performance will bounce back as expected. So really good progress around the cancer. And again, the way in which some of that being delivered is by taking a Cheshire and Mersey waiting list approach to certain conditions and access. So finally, I'll just segue, if I can, into absolutely recognising that some of the shortcomings in the way that we are presenting the performance report, and have done since our establishment, just to signal to the board that something that's been asked for a while is that we have developed an integrated board report, which has been owned and developed by a significant number of people around this table and a significant number of people that aren't. It has been shared and socialised with certainly Tony as the lead of the Quality Performance Committee. We will run that revised board reporting through committee, and the board will receive the new format from December. I hope that achieves some of the initial challenges around the ability to triangulate across provision, finance, workforce, patient safety, access, as also in a clear way of showing the triangulation across provider and place much better than what we see in this pack. So, as I say, that will come to board in November. So I'll pause there for questions, if that's okay.
Thanks, Anthony. Any questions, comments? Paul? And Anne?
Thank you, Chair. In the action log, we've got that dementia diagnosis is going to be an issue. I'm just wondering when, Anthony, you'll be able to bring that to the board. And also, I'd be interested, as a separate issue, and I don't know how possible it is, around incidence of people with learning disability and a dementia diagnosis. I think that would be particularly of interest, and linking back to, I mean, the health checks. We're seeing real improvement in the health checks for people with learning disabilities, which is to be welcomed. But I'd be interested, as I said, in understanding the levels of dementia as well across the population.
Yeah, that's absolutely fine, Paul. I mean, certainly in terms of the action around dementia, we said we would bring that back, or I reported earlier that we'd bring that back to the board in November. I think it's worthy of a discussion at Quality and Performance Committee about the metrics that we'd want to see at committee or on a routine cycle, and whether or not that warrants inclusion in the board report. I'm just conscious that the board report could expand exponentially, so we just need to be able to maintain the focus on the areas that we think are of the most importance. So maybe a further discussion at Quality and Performance may benefit that.
Thank you. Anne?
Yeah, the thing that concerns me most in the acute part of that discussion is the ridiculously high levels of bed occupancy we've still got when it's been, you know, September, but even August and right throughout the year. And we aren't even in the winter. And sometimes when the figures are quoted, it's not always clear whether it's general and acute beds or whether there's other things in it and whether we've got the specialist trust in and all that sort of thing. But if you do the general and acute beds, the bit that is relevant to this, it's absolutely sky high and over 100% in some places even now. And it's not winter yet. And we haven't got anything particularly swirling around out there at the moment. And it's just going to get worse. And, you know, just, I know we all know this, but the consequence of the high level of bed occupancy is that we then get the problem of that backing up into A&E. A&E cubicles become completely compromised because generally, you know, a trust has got about 35 cubicles and about 60 patients who haven't got a bed. So there's nowhere to put the patients, you get the corridor care, you get terrible patients experience, you get absolutely stressed out staff who are, you know, dealing with this nightmare situation every single shift they come into. It's no wonder people don't want to work in that environment who would. And then you get the ambulance delays on the back of that, which is absolutely, you know, a catastrophe for patients waiting too long for the ambulance, you know, for the condition they're presenting with. So it's like that one statistic, you know, is the kind of barometer of everything. And that's the one statistic and all that. And I mean, all of the stuff about the diagnostics and the cancer and the electives, you know, I feel like we know what the problems are, we know what the solutions might be. If industrial action wasn't happening, we'd be doing better with it. But it's all under control. But that one thing is going to derail everything else and just not have us in the place we need to be. So, you know, we need to get in a better place on this before it gets any closer to the winter than we are now, because we aren't in the place we need to be at this point in the year.
Thank you, Anna. Absolutely, you know, critical issue. And there's a question that perhaps I could ask you, which is related to this, and that's about, we set out a trajectory for reducing the length of stay for people with, for those people who've got staying more than 14 days. We set out a trajectory that we expected to achieve by October, I think, and clearly we're nowhere near that trajectory about people staying 14 days or longer. Well, I guess why? And what else do we need to look at and do to be able to unlock that piece that could help the utilisation rate that you're articulating about G&A beds?
It's kind of loads of things, isn't it? I mean, we just seem to not have enough beds per se, and then we've got the problem that many of the beds are blocked by patients who could be receiving care elsewhere and can't. And then, you know, we've got that variability around. You know, Anthony was talking then about the deflections from the ambulance service, and we know we're in the bottom part of the league table. Not every single one of our places, but almost all of our places are right at the bottom end of that. Now, again, you know, that might not be patients whose admission is avoided, but it's at least their attendance is avoided. And then, you know, at least you haven't got all those patients in A&E as well, all needing to be cared for and just crowding the place out. So there's things that we know we're not really great at, and we're not making the progress that we need to be really focused on. That's the thing that's going to derail us more than anything is going to derail us. And we just need to have, I think, much more concentrated attention to what are the things we could do better at much more quickly. Because I mean, some patients who are in for more than 14 days need to be in for more than 14 days. But we know, you know, we've never cracked that not meeting the criteria to reside thing to the extent that we need to. And I know all the reasons why that's really hard. But we just need, it's just something I think we need to be have, you know, a real focused effort to try and make some rapid improvement quickly. Because the other thing that's going to give as well is you'll start cancelling electives because you've got no beds to put the electives in. We're already all having conversations about flipping the surgical wards into medicine and all that sort of stuff. Well, that just, you know, given where we are on electives, we could do without doing that, really. Patients getting their appointments cancelled for another reason, which is, you know, not the pandemic, not the industrial action, but now it's because we haven't got enough beds to fit the emergency patients in. It knocks onto that too. So it's the one thing. I just think we need every brain you know, we've got to be concentrating on what are the fastest things we can do.
Thanks, Andrew. Good articulation of the issues. We'll hear later on when we come to the winter plan more of these issues. Let's focus some of attention. A cheer from the audience when we talked about beds. It reminds me that it'd be really good to hear about our utilisation of the virtual beds and progress we're making there. That'd be good. So if we could go on to quickly.
Well, just a quick one. I mean, thank you for the reports. I mean, they've developed well, and it's good to hear they're going to be down to place level. What I'd like to understand is what accountability will place have for the delivery of them, and what delegation have we already given or proposing to do around our service delivery and finance? Because one of the objectives of an ICB and ICS was place was the centre of attention for that interface. So how do we get that and make that work? And is it something just for the ICB, or is it something for the ICS to hold the local places to account? So where are we up to in terms of that delegation?
So it's an excellent question. I'm going to ask us to hold that, and through Claire's work on understanding our operating model, which we'll discuss in future meetings. Well, let's return to that question, because I'm not going to take any more comments, Claire. We're just running out of time. So if we can go on, the report was here to note. Thank you, Anthony. If we could go on, Tony, to the report of the Quality Performance Committee, please.
Thank you, Chair. If you take the board to section 4, the matters escalated. I won't make any more comments on the mortality reporting at East Cheshire Trust, but except for me to say that this was an excellent piece of work led by Rowan, but certainly very active work done by the committee to understand the challenges and support the outcomes. Liverpool Women's Hospital, this again was a new avenue for us to work in. The Emerging Concerns Group model, put together very ably by Kerry Lloyd, our Deputy Director. This is different because, as Anthony pointed out before, we used the word triangulation. What we very often don't do when we're looking at quality and safety is we look at the broader issues. We tend to look at one narrow issue instead of the broader one. So this looked at intelligence related to quality, finance, performance and workforce, and we concluded that the Trust should move into an enhanced oversight status that would further support the work being done to improve performance. Improving access to psychological therapies, following again information about serious incidents involving patients waiting for those services or receiving those interventions. The committee requested additional assurance as to the risk assessments and triage and waiting times from the lead provider collaborative. We had a very detailed presentation, a very helpful presentation from them, but we still remain concerned and want further assurances to the system around internal weights. I won't go into detail, but that seemed to be a particular area that needed exploration, and we'll probably want to consider looking at contract oversight of those services. That's it. Thank you, Chair.
Thank you, Tony. Any questions or comments for Tony? Thank you. If we go on to the finance report, Claire, please.
Yes, thank you, Chair. So the report that you have provides the position on our financial statements for the end of month 5. And you'll see that we have slightly adapted the format of this report to match the new cycle of business that we're picking up through the Finance Committee and the sequencing of that and the new sequencing of the board meetings. So we did a detailed deep dive on the financial position in that Finance Committee last week, and Erica's report will be read alongside this report today so that you can get the balance of both the headlines at month 5 but then the detailed review of the month 4 position that we did last week. So I'll start off with the headlines of month 5. You can see from the paper, and you'll remember, I'm sure, that we agreed a deficit plan for this year across our system with our regulators of £51 million. And the reasons for that predominantly around the cost of the new Liverpool hospital in year. But we've discussed how that plan was generated. The profile of that plan through the year means that we have assumed that a lot of the efficiencies and transformation that we are pursuing will impact towards the back end of this year. So the year-to-date planned position was that we have a deficit of £74 million at this point. In actual fact, the deficit at this point that we're reporting is 124 million. So we're 50 million pounds worse than we expected to be at this point in the year. And when you consider the fact that we've already profiled some fairly ambitious efficiencies in the back end of the year, that makes it a very, very challenging and high-risk high-risk position. So I've set out in the paper the key drivers to that. There are a number of things that are happening this year that we had not anticipated in the planning process. One of those is the continuation of the industrial action, which is having a significant financial impact on across a whole range of NHS organisations, but within these numbers particularly are NHS providers. We've also seeing much higher levels of inflation, particularly around continuing healthcare and prescribing costs and drugs costs, than nationally was expected and that we've been funded for. So you can see that variance that we're reporting at the moment is predominantly prescribing inflation accounts for about 19 million of it, and industrial action accounts for about 11 million of it in the year to date. And there's a series of other risks that I'm reporting in the paper, and I won't go into the detail, but happy to take any questions. I think just one or two things to draw out. There are a number of things there that I've just described that is not easy for us to control locally, but it's really, really important that we continue to focus really, really clearly on some of the efficiency commitments that we made in our plan and to pursue those cost improvements. And whilst there are a number of factors that are making that difficult, and the levels of non-criteria to reside that we've already talked about does make some of those efficiency plans difficult to deliver on. In actual fact, the performance of the system at the moment is holding up really well on our CIP recovery, cost improvement efficiency plans. So there's a table in the pack that just describes how that performance has behaved over sort of the last 9 years. And we really are back up to levels of pre-pandemic, almost delivering the best levels of recurrent efficiency that we've delivered in the Cheshire and Merseyside NHS in the year to date, with ambitions to do even further by the end of the year. So I think that's a real testament to the level of hard work going on in every single organisation in the system. So I'm not going to dwell any more on the year-to-date position. I would draw your attention, though, in the paper to the risks that I've described between now and the end of the year. Some mitigations we will continue to pursue, lots of conversations at a national level around the impact of strikes and any mitigating funding or relaxation of targets that may come down the line as a result of that, which we still don't know. When we do, I'll obviously update the board. Lots of discussions with organisations around looking at what support we might need to put in place to further improve the position and take those recovery actions. Probably just at that point then, just open it up to questions in the board for the board members. Or I don't know whether, Erica, you want to comment first?
Should we ask Erica to give your report and then we'll see questions and comments after that?
I wasn't ready for the Passover, sorry. So as chair of the finance, there was 3 main areas that I wanted to summarise from month 4 and from month 5. So with the change in sequencing of the boards, we've had the opportunity to do some really big deep dives in the 2 most challenged budgets, which you've heard about from Chris on continuing healthcare. There's a review being undertaken on that, so we could really understand the numbers behind that. And also in the prescribing, where there's a further review being done as well. So it has allowed us that opportunity for the whole committee to sit down and crunch those numbers, which has been really useful. The second one is really driving consistency. So we're looking at driving the consistency of clinical policies across the whole of the system. At the moment, the ones that are coming through to finance and for recommendation are the ones at 0 cost, where the emphasis is actually ensuring that the quality for our patients remains there as we align them across the whole system. And I think the third thing really that Claire mentioned there, if it is
positive news, which I think is always good to add to this board, is the changing gear across the providers on the cost improvement plans, and Claire's alluded to that. Going back to pre-COVID, we're actually hitting figures almost the same as those now, and there's a big expectation that is going to be met by the providers to come pretty close to the sort of 4 and 5%. So those were the main three things really that I just wanted to summarise to you from the Finance Committee. Thank you.
Thanks, Erica and Claire. Any questions or comments? Finance reports. Steve?
Well, thanks so much for the report. I mean, obviously the £50 million position over and above the planned deficit is a concern. I think you've explained that. I think as we mature and develop as a board, it's the ambition to have the local authority financial reports alongside this actually. If they were presented today, it present a very sorry state, because obviously demands on services, essential statutory services, and also the increased costs of those services. A number of councils around the country are rumouring they're going to announce 114 notices, which is essentially a statement around bankruptcy. It's not quite as bad as that. I'm not aware any of our 9 councils are about to do that, as we've seen in Birmingham since we met. But the situation in local government is very, very difficult indeed, and we're only allowed to put our council tax up by a capped amount. 2% of that goes to social care, hardly touches the sides in terms of the costs that are going forward. So I just wanted people to be aware. I think we'd be good at some point, if, on occasion, not every board meeting, perhaps twice a year, we have a paper that explains where our 9 local councils are in relation to their budgets.
I guess it's useful to, it's very, very useful, Steve, to have that awareness come to this board, I think. And on top of that, I suspect what we need to do is to think about the risks to the finance and performance of that we're responsible for, and how that correlates to those risks. That's okay?
Yeah, absolutely.
Thank you. If report here to note, if we could move on to the report of the Audit Committee, please, Neil.
Thank you, Chair. Just briefly, just to say the audit plans and counter fraud plans are all up to date, nothing to report. There's an issue with the dental contract, which we're looking into. We received the external audit annual report, and that was very complimentary. Whilst there was 12 recommendations, they were not serious but helpful recommendations, and they were very complimentary at the state of the ICB during its year. So that was an excellent report to receive. We reviewed our terms of reference, and they're outlined in the report and attached to it. So the recommendations really are to note the meetings and approve the amendments to the terms of reference.
Thank you. Before we move to the recommendations, any questions or comments on the report? The 2 reports out in front of us, board report and the annual report, audit report, should I say? No, thank you. And seeking your approval for the amendment to the terms of reference. Be happy to approve that. Thank you. Tony, can we go to the Remuneration Committee, please?
Thank you, Chair. I'll try to be as brief as Neil on this matter. The Remuneration Committee, though, did get through a tremendous amount of work during its first year, and I'll just ask you to note that the annual report is attached. I'd just like to commend in particular the enthusiasm of the committee for dealing with some rather complex issues, and the support we received from our Chief People Officer and our Associate Director of Governance. A number of approvals were made by the committee: on-call payments, establishment of the Deputy Chief Executive, and an important minor point there, but it's worth mentioning, move on the legacy issues that we've got around pharmacy, optometry and dental roles. Progress being made on those to establish remuneration for those positions. Important discussion we had on fitness, the fit and proper person test, and you see in the document there we've already made recommendations on how to progress that, and it is fair to say that it's progressing very well and looks to be absolutely on time and a very solid piece of work. One area that I can't progress satisfactorily is our recommended terms of reference. Matthew and I got engaged in a debate about one issue that's actually preventing us approving all of the terms of reference. It relates to the non-exec director remuneration issue and how we manage it. So save that, the terms of reference are completed, but because of that item yet to be resolved, we can't actually ask you to approve the terms of reference, but Matthew and I will get that back to the board as quickly as possible. That's the Chair.
Thank you, Ted. Any questions on the report itself? No. So this is a meeting in the public and we don't take questions from the meeting. We're happy to chat afterwards as normal and we'll bring that to life for you. If we move to the terms of reference approval with the caveat that Tony's put on, people happy to do that, and Tony will, outside of this meeting, approve that? People happy to approve that? Thank you. So if we could go to the report of the Primary Care Committee, Erica, please. Oh no, it's Claire this time? Oh, is it Erica? All right.
Yeah, it's going to be me. I'll shout as much as I can, thank you. So I'm also the chair of the Primary Care Committee, so 3 items again just wanted to highlight to you. So within each of the Primary Care Committee meeting now, we have a detailed discussion for awareness and assurance across the 4 contractor groups that we had on the system pressures. So what we discussed this time was the winter challenges that we all know about, also the return to school and what extra pressure that puts on those contractor groups. The change in policy regarding the COVID and the flu national policy, and also some incidents with security and well-being regarding our own staff in premises. Those were the 3 conversations this time. The second point was the primary care access plan. This will come to this board in full detail in November, but we're holding discussions around those 4 pillars. So they're all about empowering the residents, so digital access, self-care, implementing modern systems, so getting those telephony systems right, getting them robust, workforce, recruitment, retention, and also the estates that our workforce are in, and also reducing bureaucracy and simplification. One example with that is we were having discussions around that transition of sort of communication and actions between primary care and secondary care. But that full report will come to board in November. The final one was the GP survey results. Probably not unsurprisingly, but disappointingly, there are those issues around access, and hence the Access GP plan that will come to you. But what there was an increase in satisfaction on the actual care, that when you got in front of the clinician, both in person and aftercare was improved. So that's it. Thank you, Chair.
Thank you, Erica. Any questions for Erica? Happy to take the report as note. Thank you. Next one is for me, which is the report of the Chair of the Women's Services Committee. You can see in the paper that the main activity of this committee remains to receive updates from other bodies, like the Women's Services Programme, the partnership board between Women's Hospital and Luft. We received finally thankfully an update on the recruitment of the Programme Director and the independent clinical SRO for the programme, so they are now in post finally, which is really good news for us. We also had an outline and presentation on the Care Quality Commission report for the Liverpool Women's Hospital to seek to understand whether that was highlighting any more or new risks to us. And in addition to that, we took further time and effort to understand how we could properly embed the governance of the programme in place, which is principally around how established or not the working groups to support the programme was. So we continue to develop the workings of the governance and hear from the wider set of organisations that are involved in this work, what updates and information they can give us. Importantly, we had again another conversation and another presentation subsequent to the meeting on emerging ideas and thoughts about engagement with the public, interest groups, and of course patients and staff of the services affected. Chris?
Thanks, Rad. Just a point of accuracy under the recruitment of the programme director. The programme director is Claire Powell and not Claire Wilson. I'm sure Claire will.
Oh yes, it is. Thank you. Happy to take any questions that's here for noting. Thank you. If we could go to Claire, Transformation Committee update, please.
Yes, thank you, Chair. So just a couple of points to raise. So the committee approved the specialised commissioning PDAF, the pre-delegation assessment framework, to return to NHS England within the national timelines. You'll remember the board gave delegated authority to Transformation Committee to do that, so it met all our requirements. So we'll be looking at a future meeting, more update on the safe delegation framework, the target operating model between NHS England, North West and the 3 systems, and also the implementation plan for taking on additional responsibility for the 59 specialised services. We also received an update on the current allocation of transformation programme monies and how we're spending those for both 22-23, and we've been able to bring back some funding for the deficit position, but also our programme to invest more funding in transformation programme. Thank you to Ian in his new role as Director of Population Health, providing more grip and assurance around the Treating Tobacco Dependency programme, so we've got greater assurance on that programme. And just future work will be around discussing what additional programmes report through the Transformation Committee, one of which will be Pillar 4 in the ICB finance strategy, which covers the at-scale and Place Plus transformation programmes. Thank you.
Thanks, Claire. Any questions or comments for Claire? No, thank you. I do need to go back to a report I need to give, which is the on behalf of Councillor Louise Gittings, who is the chair of the HCP, the Health and Care Partnership. From the meeting in July, you can see the papers in front of you. What I read on behalf of Louise, I'd really like to convey this sense, which is we can see the gathering momentum that there is behind the partnerships that really are the engine rooms and fire up the ambitions of the HCP. And really importantly, the Healthcare Partnership is coalescing down to a few priorities, which we then subsequently discussed in the September board. Coalescing around a few priorities means that we can have more impact across Cheshire and Merseyside on things that are most important to us primarily from a social perspective. So good progress being made there, and I'm going to be pleased to, I'm sure, report on behalf of Louise at the next board about the September committee. I'll take a question, Paul.
Thanks, Stuart. Well, just to support that I've had positive comments from my colleagues in the local authorities about the development of the partnership and the hopes for the future, and particularly that joint approach to tackling health inequalities, poverty and deprivation in general, and people are very positive about the partnerships that are being made.
Thank you, Paul. Happy to take any questions, comments? Rowan?
Thank you. I guess it leads on from what we heard at the very start of the meeting from Diane, where we have shown the power of that partnership working. And I would really like that we continue to work as hard as we can, that the intelligence that we are now gathering about the most vulnerable people that we care for whom the solutions may well not be entirely healthcare. In fact, you know, that might just be something at the edges. But the partnership working, the social prescribing, the access to everything they are entitled to, that we use that intelligence to the very best use possible within that partnership. And I will pick up outside the board, particularly with Ian, how we make sure that that intelligence works as hard as it can for those who deserve that. Thank you.
Thank you, Rowan. Report was there for noting again. So, Rowan, should we move to clinical and care constitution, please?
Certainly, Chair. Thank you very much indeed. I hope there's some slides that will now appear. Okay. Thank you. And with a bit of luck, there we go. brilliant. So, a huge amount of what we do, I think, needs an agreed set of behaviours and principles that are robust, that are transparent, that we can all agree with, and that therefore will define the way we carry out our business. And that's why I wanted something as boldly named a constitution, because when we sign up to that, it does mean that those are the behaviours that we will exhibit through everything that we do. And so this sets out these principles that we will adopt across the system. And it is an agreement and a partnership that in all that we do it in the very best way to serve our population. Now, what I didn't want was something that was a 40-page document that might sit on a shelf and never be read or referenced, but rather something that might sit on one page, a busy page, and fear not, we will move beyond this to look at some of the elements, but something that we can continually reference in the work that we do, in the papers that we write, in the projects that we deliver, in the priorities that we set and we agree, and in the way that we work, therefore. And so, whilst this talks about clinical and care, it will certainly reach into the partnerships that we live in as well, because this is what will help drive our population health strategy that absolutely needs to be delivered in partnership with local authority. Colleagues will have heard me say 80% of your journey into ill health happens before you ever see a doctor, and how we address that. And I'll, at the end, mention the long list that we're working on just at the minute. And that all of this is designed to help us get behind the health inequalities that exist. So at the heart of this, and you've heard this already this morning with the fuel poverty work, that we must shift from reactive healthcare to proactive. That we must have our clinical professionals at every level of our decision making, and that the culture is one of shared learning and collaboration alongside our patients and the communities where they live. This cannot be a continual world of paternalistic medicine. It must be done in partnership. That we must always evidence what our investment achieves and demonstrate the quality that it delivers. And that through our collaborations, our education, our modernisation, that we must influence these wider determinants. It cannot just be done from within the NHS. And as such, we have some pledges. And nobody will be surprised that the first pledge I have for us is as simply titled quality. This must be at the heart of everything we do, with high-quality, resilient services that always follow the evidence. That we continue to use the health intelligence that we have and evidence the difference that we make. And where we face multiple demands, that we will prioritise using something that is robust, clinically led, and that we respect Michael Marmot's review work around proportionate universalism. This must be fair and equitable. And wherever we can, we will contribute to that evidence base, not just draw on it. Collaboration has not traditionally been the way that things have been in the NHS. The Lansley reforms put us on a path of competition, but it must now be one of collaboration. The primary secondary care interface, and already Jonathan Griffith's work on that has been really important to make things run smoothly, avoid duplication of effort, not have patients bouncing around the system, and that we step out of the silos that we've traditionally worked in. That has to be a commitment. And it's not just about what we do as professionals, but empowering our population, starting to shift some of the health behaviours of those that we care for to access health in the very best way, and to therefore co-produce not simply be paternalistic. And essentially, that where we are going to do something in one part of the system, it does not cause unintended consequences in another part, that we hold on to that. One of the challenges of being a big system, but an important one. All of this is about improving health outcomes. Wider determinants are essential, and that's why I want our local authorities to be part of this as well. And it must be about improving health, as I've said, not responding purely to sickness, that it is equitable and fair, but essentially that we train and prepare a workforce to deliver this. I want everybody in our workforce to recognise this constitution as the way they will be supported to go about delivering high quality care, and that all of our organisations therefore feel supported to do all of that. Ultimately, this comes down to value, and let me be clear, value is not just about pounds, shillings and pence. We've heard the value this morning that Diane has driven for her patients. And yes, it might be the money that lands in the bank account, but the value goes way, way beyond that. But we will demand that our projects evidence their positive impacts, not just say it, but show it. That our improvement methodologies become consistent and recognisable, so that no matter where you are in the system, we are working in the same sort of a way. And I am always delighted to work differently, but we must show that differently absolutely adds value and is not just for the sake of doing something differently. And all of this must be about quality, effectiveness, and improvement on the way. There are a few enablers that make this happen, and without those, it won't. And that, of course, begins with the engagement that we've done already across health, social care, voluntary community. This has been with our chief executives, this has been with our medical directors, this has been out there with our clinical leaders and GPs. That our strategy must be informed by the richest intelligence, and this is where our investment into digital is so important. We must solve the right problem, and we must solve it in the right way. And that the partnership with our incredible academic institutions here in Cheshire and Merseyside is an essential part. They're already showing their worth. They're already attracting further investment into this area because we are world leading. And that where we create the leadership framework, that we must equip, develop, find, inspire our next leaders to step into this space as well, so that this becomes absolutely the culture of us in Cheshire and Merseyside, that this becomes the way we do things round here, and that this is something that will be recognised and valued, I hope, by our staff, as well as those that we are here to serve. So, there are some obvious next steps, bringing people together to really make this work now. But the two important things that will flow from this are, firstly, a population health strategy that says, what does our population and community here in Cheshire and Merseyside need to have the very best outcomes? And this is the long list. Because I suspect that when we look at the long list driven by the intelligence, it won't just be health. It may be things like free school meals for children will mean that children are less likely to become obese, are better nourished to learn in school, and will have better health outcomes as a result. But that is not within the gift of the NHS to do. But goodness me, I'm sure our local authorities and partners would want to know what part they can play based on the evidence. So the long list will then allow us to have a short list of what it is within health. And I suspect that it will not be a list of pure diagnoses. I think it will be segments. It might be segments like frailty and falls in the community. It might be those living with complex lives, that really difficult, indeed toxic combination of physical disability, mental health problems, drug and alcohol misuse, and children in the care system. That toxic combination sadly impacts 8% of our households here in Cheshire and Merseyside, which I think is a shocking number. But even more disturbingly, that 8% of households are currently consuming around 36% of all of our health and social care resources. So, we talk much of the challenges we face with finance, but let it all come back to the quality of care that we deliver, that we solve the right problems in the right way. And I hope that through this constitution, the board will want to endorse that this is the way that we will do things round here, and that we then lead on to the so what, that this then forms a set of strategies and approaches, the agreed small number of priorities, that we can make sure we derive the very best value for those that we serve here in Cheshire and Merseyside. Thank you, Chair. I'm happy to take any questions.
Thanks, Rowan. Any questions or comments? Claire?
Thank you, Rowan, and thank you. I know a lot of people have been involved in this, so thanks to everybody. I think it's just really important that we use this and build on it in terms of the refresh of the healthcare partnership strategy. We'd made a commitment to revise that and really build on Altogether Fairer and the local authority health and wellbeing boards, health and wellbeing strategies. So I think it's important that is our key ICS document. This underpins it and supports it, and we use that document rather than a separate population health strategy. I think to take this forward, I think it's really important we use, we bring together the work of the ICB and the HCP in this agenda. So I think I really welcome this, and thank you.
Thank you, Claire. Adam?
Yeah, I'm really supportive of this. Just thank you to everyone that's been involved and all the work that's gone into it. I suppose leading on a little bit from Claire's point, I think we shouldn't underestimate the amount of work we're going to need to land and embed this culture change almost in every place. I mean, we often describe ourselves as a really complex system because we've got 17 hospital trusts or 17 hospitals. If you think about 1,600 primary care providers that we have in Cheshire and Merseyside, embedding this right the way down is going to be really difficult, especially while we're in the process of reconstituting our primary care forum. So I think there's a little bit more thought and work we need to do around that. But I think we're somewhat reliant on our commissioning processes to deliver the benefits to patients that this brings. I think that ways of working that you called out, the primary-secondary care interface, actually the intra-primary care one as well, is really important so that we know when one part of the system has either an information need or a concern to raise, it can be done in the right way and it can land in the right way at the other end as well.
Thanks, Adam. John? Neil?
Thanks, Raj. In the digital sphere, we've started to use this as a test, really. And Rowan mentioned the close alignment with digital. Some of the work we're doing is stepping into genuine co-design and co-solutioning across multiple organisations, which hasn't happened as widely as you'd expect in the past, and this is proving a useful framework to frame those discussions and evidence-based removal of variation following the clinical model. It's already bearing fruit in that, so I think we will continue to use that as a planning tool and a context for everything we do as a system.
Thanks, Sean. Good example. Neil?
Yeah, I think it's great, and it is the way forward. I've just got one caveat, and I don't want to be a damper on life. In my experience, every service review I've been involved with, we've found a shortage of resource, of staff, of quality and unmet need. So my concern is that doing this, we will find similarly at a time when we've got a deficit of £150 million. So how do we ensure that this strategy lives within our available resources? And that's the totality of our resources, so that we don't take incremental decisions, which are the right things, but we're compromising other services because of the resource shortfall, increasing weightiness. So I'd like to see something whereby the broader financial strategy, I know you've been working with Claire on clinical and financial strategy, but not just look at individual investments, but look at the totality of the resources that we've got in ICB. So I'm concerned about that deficit's going to grow and we're going to have more flushes. So how do we reconcile that?
Rowan, let me bring you in. Let me take the questions and then we'll bring you in. Graham?
Thank you, Chair. What I wanted to say, that this effectively underpins the way we work. I think this is a really great piece of work. I think it does link directly back to the piece of work that we've got to do around the financial strategy as well. Those two things have to exist in harmony. I know the document says this, but I just wanted to pull out the particular point that I think that's already been made, because I think it is so powerful. At some point in time, we will make decisions about changing things. Sometimes those decisions will be really easy decisions to make, like the creation of hyperacute stroke units that save lives, that give better outcomes to populations. But actually, before we get into taking those difficult decisions, one of the things that we have to do to hold our heads up high, I think, to have the moral authority here, is that we have relentlessly worked to identify and drive out the unacceptable variations that exist. And I think this gives us the platform to be able to do this. So I absolutely commend this as a piece of work.
Thanks, Graham. Louise?
I really welcome it as well. I think it's a great, it gives us something to hang our hat on, I think. But I guess my question then is, how will we have assurance that we know that this is working? And by we, I guess I'm talking about people and patients. What would you expect us to see? And I guess it's possibly for the comms piece that comes with this. I'd ask that to say what that will look like for an individual. And also in its ripple down, when will I, as a health and wellbeing board, see this is coming in and being discussed as a way of working, and how will that get into our neighbourhoods and our care communities? I accept that's a large question, but my point being, how will we see that this is actually in place?
Thanks, Louise. And Claire?
Yes, thank you. So my question links a little bit to what Neil was saying. And I suppose, and I know you've got some thoughts on this, Rowan, but it's making then this a reality in terms of our plans going forward, isn't it? And Claire described the interplay with the healthcare partnership strategy and the public health elements of that strategy. You know, we're working on the financial strategy as well. You know, there'll be a workforce strategy. There'll be individual organisation strategies, and it's knitting that together so that we're addressing on all aspects of the objectives that we've got to deliver on, and I know that you've got clear views about how this work can help us with the financial elements of our strategy and the sustainability from a financial perspective, because of the way we can use the intelligence into action, as you've described before. So I suppose there's two elements to my point, really. The first is, as an executive team, I think we've got to think through how we make this a reality, stitching all of those aspects together. So that's more of a comment than a question. And then the second is, just if you want to make any references to what we've already talked about around the interplay between this and the financial strategy and how complementary they are.
Thanks. Ron, could I ask, just because of time, let's Louise's question about impact and how do people see it. The alignment question about affordability, finance, just give us some views.
So that's why I wanted it on a single page, Louise, so that this must become something that everybody that works in our system recognises. So we met yesterday with our entire medical directorate to work on this together, and that our place leads, our clinical leads, we will work to see that this is in every practice, that it is visible to everybody that steps into healthcare, that colleagues like yourself, voluntary sector, have the role to play in disseminating this. All of our medical directors within secondary care have seen this, and it will be cascaded down through them. I would even like that we get to the point that some of the cover sheets to our papers ask the question, how does this project align with the Constitution? So that this just becomes familiar language, stuff that we all comfortably talk about, and where things are difficult and challenging, that it cuts through some of the emotion of difficult, challenging conversations, because we know we have all signed up to work in this way. So there's something about the cascade, and there's something about making it common parlance for all that we do here. And that's exactly what I'll be working on with our comms team, that it gets everywhere, hence it does distill onto a single page. We've talked about it in the meetings, how we talked yesterday about podcast, all sorts of different ways of getting this out there. It's going to take a little bit of time, but this must become the common language of the way that we design and deliver care. Claire and I have talked a lot. This is the enabler for when we're under financial challenges and pressures to look back to it and say, we've got difficult decisions. Are we clear that we're following the best evidence when we're making this financial decision? If the resources are limited, show me how we are following the proportionate universalism, that we are, particularly caring for those who need it most, that it tackles the health inequalities. If we can tick those off in all the challenging financial decisions that we need to make, then it remains transparent and defensible and robust. So this is going to be tested in the work that we undertake, but that's a test that we will welcome and work through.
Thanks, Robin. Joe, and then, Hilary, and then Joe.
Yeah, a great piece of work, and I think it should be disseminated and embedded in the way that you say, just a plea that we make this a multidisciplinary effort in the creation of how we do that. There's a huge nursing workforce out there as well, an even bigger workforce in social care than there is in health. So it's a real plea that we can have some assurance that that's truly multi-professional as we discover how to do this well. And I think there's going to be quite an ask here in terms of our provider boards. And so I think that needs to be really articulated well in order for them to sign up to that, because they'll probably have their own constitutions and charters, as you've alluded to there as well. But unless we get that groundwork in terms of expectations articulated, we could have a bigger battle than a bigger challenge than maybe what we're anticipating. Thank you.
Thanks, Hilary. Joe?
It's very good. Rowan, hugely supportive of this, as you know. But I suppose my question is about, it's not the first time these sorts of things have been talked about, particularly the use of evidence-based care and those sorts of things to shift better value for money into different sorts of activities. Where will we see the sort of reflections on why it hasn't happened in the past? Because this gets difficult, doesn't it, where it hits that illogical moment of asking people to change their behaviours. It's relatively straightforward to sort of campaign in poetry. It's the governing in prose that changes things. Where will we reflect on things that haven't happened, or why things haven't happened in the past and how difficult it's been? Because I do agree, I think this is central to us recovering the financial position, the health inequalities position, all of those things. But it's really difficult. So it's not really I don't expect you've got a plan in the back of your head right now, but it would be very good, maybe in a board development session or something, Chair, to reflect on our combined knowledge on this, why things happen and why they don't.
I think that's a good suggestion, isn't it? Mm. Thank you. Thanks, Joe. Really, really important. Let's learn the lessons of the past. Oh, I might be reading this wrong. I've just got an ask of you. It's on Appendix 2. And it's just the way the diagram is positioned. And it can be read as though there's a top-down approach on the system place down to neighbourhoods on the left-hand side of the diagram. I think it doesn't mean that, because of course our planning is always about neighbourhoods, place and up to system. But clearly this diagram is an important diagram. Can we see whether we can think about
Yes, of course, happy to, Chair. That's fine. Thank you.
So this paper and strategic approach is here for approval. Are people happy to approve it? Lots of conversations about how are we going to demonstrate the impacts on people in Cheshire and Merseyside. Alignment, so on and so forth. People happy to approve it, but we understand the immense amount of work that's going to come and the really good idea. Let's devote a board development session to make sure we have a good understanding and contribution. Thank you. Should we move on to the winter plan?
Yes, thank you, Chair. So the report you see in front of you, whilst relatively short in size, is drawn from 9 individual winter plans that have been developed at place level with total inclusion of all system partners throughout. And the sum of those plans and indeed how those plans have turned into numerical analysis from the providers of services is what forms the basis of this overall summary paper. What I'm keen to impress is that whilst this is the winter plan that was submitted at the start of September through the NHS pipeline, and that will be subject and is currently subject to a level of support and stress testing in terms of its development with NHS England, it's not the end of the process, clearly. You know, this gives us the heads up as to what the challenges are that we are facing based upon the plans that we've already developed. There's a similar process to some extent around local authorities and the use of social discharge funds, which is on a timescale at the end of this month. And I guess all that does is it draws our conclusion that we have to spend the next certainly 2 months continuing with this at the heart of everything we do operationally to ensure that we're in the best state of readiness for winter, with everybody sharing the same grave concerns of the pressures that winter brings upon us. In terms of this year, and one element that marks it out as a further challenge for everybody within the system is that whilst additional funding has been provided to make additional bed capacity recurrent, and indeed there has been some additional funding through the social care discharge fund to local authorities, and indeed a share of tier 1 monies, as it's called, direct to local authorities to reflect the particular pressures certain parts of our system are under. What we haven't seen this year, and was never really anything other than what was expected, is there hasn't been any additional winter funds to draw down upon for additional schemes. So a real component of the way in which places have tried to coordinate and develop the plans is based upon what we know works well, and a reworking of existing services and provision where it feels clinically safe to do so, to try and reutilise the resources in the best possible way. In terms of the headlines that we see, I think probably before I get into what clearly will become part of the main area of focus as we move forward for the next 2 months, this is not to put a shine on the current position. We are in a very challenged position in terms of urgent care right now, as Anna's articulated earlier and some parts of our system feature in some of the most pressurised systems nationally. But it is worthy sometimes of just looking over the rear shoulder to see how far we've come. And if we look in terms of figure 1 in section 3, there's 4 key metrics there, and whilst no one would argue that the current position against all 4 of them is anything other than something that we continue to tackle, it is worthy of note that against some of those key metrics, the position that we found ourselves this time last year and at this stage of development of the winter plans, that there has been some progress made. If we look forward to what the plan shows us from a numerical capacity, it highlights, as you can see in table 1, some of the challenges that we know exist now, but to articulate that, eyes will be drawn to the general bed occupancy and the number of general beds that we are planning for. At this point in time, we have about 5,500 general and acute beds open across Cheshire and Mersey. The plans will show that we plan to increase that to over 5,700. But that is slightly lower than what we had at the peak at the peak of winter last year, and we understand the reasons for that. There was the restart of the maternity services at East Cheshire. That bed capacity had previously been used for general pressures during last winter. We know we've got the ongoing challenges and dynamic nature of RAC. But we also are aware that you know, there would be further contingency of 105 beds should we be at the point of having to pull on that lever in terms of extreme pressures. But what we see with the plans and the planned beds that we have is that the providers are pointing to a level of occupancy and indeed non-criteria to reside occupancy very similar to what we've currently got. And overall, a very slight improvement on what was originally thought when the original operational plans were drawn up in April. But this is far from comfortable, as we all recognise. And as was pointed out earlier, there's a nuance within that in terms of the general acute beds versus the specialist beds. So it's a plan, and one could argue the winter plans are there to mitigate against the additional pressures of winter, not necessarily to turn around urgent care delivery. So on the basis of that, the plan would suggest the resources would be in place to try and hang fast with the position we are currently in. The bit that we know is an opportunity for us and jumps off the page is the virtual ward capacity that was mentioned earlier. Our virtual ward capacity usage is relatively low. It's around 60% of capacity. We took the decision earlier in this year not to expand that virtual ward capacity any further until we were able to use the existing capacity to its optimum, and that remains a key focus of our plan moving forward. And the Mental Health, Learning Disabilities Community Services Collaborative are taking that as the lead body to lead on that. But we do have a chief executive leaning across from the CMAST Collaborative to work on that interface of focus. I won't necessarily draw on too much the detail of the individual sector plans that's within this paper. We've got a number of place directors present. We've got providers equally who will have seen the winter plan produced, will have signed off that through their own local organisation, and we can quote some of the key examples on that. But what I'd say for the purposes of this is that, you know, all the governance and the arrangements that we had in place in terms of setting up the winter plan to this stage are continuing. There are weekly place-based winter plan meetings taking place. There's an ICB-led Cheshire and Merseyside oversight group taking place every week with total inclusion from all parties, and we will continue to drive forward on the key areas of focus that you find in the summary of the paper. I'll pause there, Chair, if it's okay for questions and possibly discussion on how we provide further assurance to the board as that development of the plan into reality takes shape over the forthcoming weeks and months.
Thanks, Anthony. Can I take some questions or comments? Claire?
Thank you, Anthony, and thank you to your team for the leadership on this. But can I just for a point of accuracy, in 6.2, around primary care, so system development funding has been made, is it available for primary care, general practice that is, but it's not to support ARI hubs. There's no additional winter pressure funding for general practice or wider primary care. We are encouraging our places to work with their PCNs and practices to look at the sort of system pressures across all access areas. But and we know that the ARI hubs, acute respiratory infection hubs, are one of the sort of high impact initiatives in the winter plans. So hopefully, you know, our places can work together with their GPs to encourage take-up of that. But just want to be clear, there's no additional winter funding for general practice. Thank you.
No, you know, absolutely you're right. You recognise that, and it's probably worded a bit clumsily. I guess what we're saying is that, you know, the additional social discharge funding pot that has been made available to all local authorities plus the tier 1 has been subject to the discussions with individual places as to what additionality that will bring, as well as the market sustainability and purpose that it had. And I think in some places were considering how they could use it based upon not only social care capacity, but also how it could read across into other functions.
Thanks, Claire. Anthony. Anne?
Obviously, I won't repeat what I said before about the bed occupancy thing, but it's like we have a winter plan that assumes levels of occupancy that just don't seem plausible in the context of the current levels of occupancy and in the context of actually entering the winter with, according to this plan, 135 fewer beds across the system than we had last year, G&A beds, which I'd love to see the mathematics that supports the fact that that looks like it's going to get occupancy levels at that level when we're just nowhere near it now. So, you know, say all the same things again as the consequences of that, but it just feels a bit like, you know, how does that work then if we're already at 100%? Most trusts are at more than 100%. That we'll have 135 fewer beds than last winter, and yet we'll have those like quite, let's say, comfortable levels of occupancy, but 93 or something would be a dream. So that'd be nice. So I hope it'd be nice to, well, maybe I'll just sit down with Anthony and try and work out how we've come to that conclusion. It doesn't feel plausible to me.
It's a good challenge, isn't it? And will you sit down with Anne and let's understand how that calculation has been made, because it's of critical importance to us.
Yeah. But Chair, I would point out that is the provider submitted plans that have got to that mechanics, but we'll happily sit down and go through the
let's understand why. Yeah. Any other questions or comments? Erica?
Two comments for me. The first one is on, I know we talked about it before, on virtual wards, and that our take-up was particularly low, on whether there was, and I know this is more of a short term, but whether there was any commentary around that, any more that we can do on that. And the only other thing that surprised me was we haven't done an equality assessment at this point, even though these plans are quite advanced. We've kind of, I think we've written in the report that we'll wait until they're totally finalised and then we'll do it. And I wondered whether we're missing any sort of mitigations doing it that way round.
I think it's a fair point. I think certainly the timing through the NHS pipeline has been very rapid in terms of the release of the expectations and the submissions on the plan on a 4-week time frame. And part of that planning round is that quality assessment is now being undertaken over the course of this month, and in the light of what we understand the additionality provided by the Social Discharge Fund will present. So I think it's a fair point, and one that we should learn of in terms of our own planning for next time around, rather than reacting as we are.
And is there anything we can do quickly to do an assessment?
Yeah, as I say, some of that, you know, is evident within the plans. I think what we'll do, we'll pick up at the next weekly group on Wednesday, how we can accelerate the delivery of that in terms of getting oversights and understanding. I'll pick that up.
Thank you. So, I'm just going to ask Mark and Alison, our place-based leads, just give us some commentary, and in particular, I'd like us to understand a bit more about the partnership work between local authorities and the voluntary and faith sectors that we think are hugely important to us, and any reflections about staff. Because clearly we can have as many beds as we want. If we don't have the staff, we're in trouble.
So, do you want me to start, Raj? So, I mean, our winter plan for Knowsley, so the population of Knowsley, is absolutely jointly constructed between NHS, local authority, the voluntary sector. So the plans that we have that Anthony's referred to are absolutely jointly constructed. I've just been emailed this morning the additional funding that's coming into us to bolster the adult social care discharge response. So signing that off jointly today with the local authority. So I can definitely give you that assurance. In terms of the plans we've got, and you know, I'm listening to Anne, and I guess we're both thinking we are places that are part of your trusts, part of your catchment. It's a larger catchment than it used to be, Anne. We are doing everything we can, and we can evidence that some of the work that we're doing is avoiding people going into hospital. So we've got a new service in our care homes that is provided both equipment and training, that when somebody falls over in a care home now, the staff have the skills, the ability and the equipment, the nursing staff there, to pick people back up safely and not call an ambulance. And we can see in 6 months of this year, that has avoided 60 people phoning an ambulance. And those 60 people may not have been admitted, but they will have been in hospital a fair time. So whatever we're doing, we're still not eating into the occupancy rate that Anne is talking about. And going back to some of Rowan's hard choices we're going to have to make, you know, we believe these are the right things to do, is to keep people where they live now, to prevent them going into hospital, so that we don't have to invest in more hospital beds, because we haven't got the staff to do both. So our plans are largely in place, looking at some of the things we can do to keep people well in their own homes. Be that NHS, and that was an example of what the NHS through colleagues in Merseyside are doing now to support that, but also in social care. So we can see in our reablement services, you know, we've got more people, again, I could give you the statistics, we've got them for a review we're doing tomorrow, but more people who are being able to be kept and supported and cared for at home rather than in hospital. But the sum total of all of that is not helping Anne in her hospital. So there's still more that we need to do. But that's a snapshot from Knowsley.
That's really helpful, Alison. Mark?
So thank you, Chair. So just to kind of build on what Alison's talked about, and it kind of circles back round to what we heard from Diane right at the beginning, because there is something about the work that we do at Place with our partners that is focused on what the root causes are of some of the demand that we see in the system. And what I heard was that this wasn't about kind of respiratory issues in terms of treating COPD or chronic asthma. It was about the root causes of sort out the mould, sort out the housing. And that's the sort of thing that we're trying to do at Place. Now, when you look at it and Alison's talked about the example of kind of Whiston and tried to take a mid-Mersey approach to this so we can collaborate across, and when I say mid-Mersey, I'm talking about Knowsley, St Helens and Halton for that purpose, is how do you collaborate and work together across the places so we get a more consistent approach to that, but there are challenges both in terms of the number of beds that are available, but then that ability to discharge to assess. And we work really hard in terms of doing that. We've got an integrated system in St Helens, and we use things like the shared care record to facilitate that, and also an integrated discharge team and having contact cares based on site at Whiston. So there's a number of things that we're doing, but you mentioned workforce there, Chair. So there is a massive challenge in terms of workforce right across the health and care system. And that's one of the things we're seeing both in terms of NHS but social care, the ability to increase the capacity. So it's great that the money's come through to social care, and I've been working with my colleagues in local authorities and DASs to do that, but the reality is that we struggle to do that. And I think Louise was spot on before when she was talking about how do you see this happening at a kind of care community neighbourhood level, because that's where we'll start to deal with some of the kind of root causes. So there's a lot that we're doing to collaborate and share, but there's some real challenges. And even though the money is welcomed, it doesn't necessarily translate in terms of the additional capacity because the workforce isn't always there.
Thank you, Mark. And Alison, really good, rich stuff. Yeah. Paul?
Thanks, Chair. As somebody who sits on the integrated partnership in Sefton, I'm happy that absolutely everything is being done to integrate our plans and ensure that we maximise use of our resources to tackle the demand. The reality is, though, that this still fills me with dread, winter coming on. Anne's touched on some of the key points. We've had corridor care right throughout the summer. It's an absolute disgrace, and I'm not blaming anybody here for that. The system, we cannot cope now. This is going to be very much sticking plaster approach, and I think, Anthony, we're couching it in very careful words. I'm not saying, but it is. Things are going to be much worse. People are going to be going flat out to try and prevent things as much as possible. And I'm satisfied, as I said, that all the plans are in place. But Anthony said no additional winter pressures resources. Why not? And I think I can be asking that politically, and I think we should be demanding that there are maybe we haven't got the sufficient workforce either. We know that. But it is going to be an absolutely horrible, challenging period ahead, and let's expect it, but let's try and do everything we can to mitigate the problems.
Thank you, Paul, and really, really well put. Alison?
Thank you. Probably just to follow on from the theme that's been today around maximising support, that's not health, but for me, obviously, the voluntary sector, having had sight of all of the winter plans from the 9 places around how each place is embedding the voluntary sector, it was quite varied, and some can see there's full integration with the voluntary sector, and some, to be fair, was quite poor. It was very much lip service in terms of what, and I think it's just not having that understanding of what's available and the support that could be maximised and used for winter, I think, to build on the conversations we've started having and probably what I've been having for a long, long time, but to keep that going.
Thank you. Naomi?
It was just to bring in a few of the different points that have been made throughout this meeting. I think, people often use the term, we triangulate data, we try and bring things together. Going back to the quality and performance report. So we're already, within general practice, we're already at 255% of telephone consultations, and we have been over the last month. And yet this is our summer period, this is our quiet period. To bring in what Claire said, that there is no additional funding for general practice for winter pressures. So if we're already at 255% working pre-COVID, how are we then expected to meet the increased demand of winter pressures without the additional funding? Yes, we've had system development funding, but that has been it's a year-long plan. Yes, it is supposed to look at winter pressures, but within the system development funding, that was not allowed to cover staff. It was not allowed to cover staff provision. So it doesn't matter what sort of telephone system you have in place. If that telephone system tells you you are number 100 in the queue and there are only 90 appointments available that day, you do not have access to that appointment, no matter how good your telephone system is. The System Development Fund does not allow for improvement in access. It doesn't improve. It doesn't allow general practice to meet demand.
Thanks, Naomi. Graham, just say a few words, because what we are clearly hearing across this board is how worried we all are about winter, despite the fantastic efforts of everybody around the table, everybody in each one of our places and our organisations to do their best. We're still really, really worried about it.
Thank you, Chair. What this will come down to is a real test of our character and our partnership. I think it is fair to say that everybody around this table would like us to have more beds, more staff, and by more staff I don't just mean in our hospitals, I mean across primary care, community services, across the social care sector, to be able to provide a better quality and a higher level of access to our population. The reality is we don't have that. And even if we have the money, it takes a considerable period of time, to grow that future workforce. So we welcome things like the long-term workforce plan that will see that increase over time. So what we've got to think about is the way we're going to operate through this winter. And I think what you see come to life through these winter plans is a huge amount of opportunity. A huge amount of opportunity to make small improvements at every part of the patient flow journey that might just make that difference. And the problem is there isn't one single magic bullet or silver bullet that's going to be a game changer. It is securing all of those small improvements at every part of the pathway. But the other thing, and what I say now about this is the test of the partnership, this is about our ability to be kind to one another in particularly challenging and stressful times, to enable there to be a degree of mutual accountability so we can hold one another to account for delivering each and every part of the process, but actually we're not going to be helped if we start blaming people. You know, we've got to be able to sit down in a room together and say, truly, everybody, whether you're in social care, hospital, community, primary care, mental health services, the ambulance service, wants to see each of their partners be a success and to support those partners in that fashion. So,
Just carry on.
So, I'll just come back to that thread. There are things we can do. There are things that won't be in our control as well. So it depends. You know, when does the flu season arrive? How well do we manage norovirus? How well do we manage other infections? If those things become spaced out, the NHS has a better chance. If those things come together, the challenges are more difficult. So we have to be on top of every single small part of this and seek those marginal gains to help the service get through the winter, to help our patients, but also to help our staff working in the front line in really, really difficult circumstances.
Thank you, Graham. So the report's here for noting. Move us on. Been poor at managing time today. John, you leading the digital paper?
Thanks, Chair. So I'll be brief. The paper in the pack provides an update against the digital and data strategy which this committee endorsed. It was actually last November, so 9 months in. The paper provides an update on some of the deliverables that have been provided in year, and some of the highlights of, not an exhaustive list, but the big themes of work that are in flight. It's a 3-year view of our priorities, and what the paper is seeking is endorsement of an approach to review, reprioritise based on a significant number of changes in terms of national targets, local context, more information that we've now got at our disposal, and a more, I think, a year in, a more cohesive strategic conversation across all our places. So we're proposing to do a piece of work to recalibrate the plan, understand in detail where we've got finances in place and where we need to put more thought to how we resourcefully finance some of the agenda. I've also agreed this week, since the paper's been produced with the health CIOs, some tweaks to our governance to have a group dedicated to managing collectively all the deliverables in the plan, and that will include place digital representatives and local authority colleagues have been invited to that. Just some of the headlines then, in terms of work in flight. Just read my own slides. We've heard already this morning around, we've now got an established population health analytics intelligence into action capability. We've got the governance now established, and we've heard just how important that capability is to our collective agenda. I'm working with Ian to make sure the population health agenda plays directly into our prioritisation work. We've deployed single common OCVC platform in primary care, done pieces of work around digital inclusion that have completed, and a number of other things. But the original strategy was most of the deliverables were in year 2 and 3, and there's some big pieces of work well in flight. The diagnostic programme, which supports the diagnostic transformation agenda run through our acute collaborative, is really attracting headlines because we're doing some genuine cross-system working. We've agreement to move to a single laboratory information system, which is a really strong signal around how we are proposing to collaborate across the system. That will give us a single view of capacity in our labs and a common language. Similarly with PACS, a single imaging solution allows us to manage a single work list. Real productivity gains in there. We're driving out patient portals across our, initially our acute non-specialist trusts, and we've learnt this week there's funding to do the same with mental health and our specialist trusts and community trusts. So we'll have a cohesive single plan that will give us a digital platform for a whole range of patient communications with secondary, community and mental health. Lots of work around waiting list initiatives. We've heard at previous meetings around the use of AI to really intelligently interrogate our surgical waiting list and identify patients who are suitable for prehabilitation, and that's really bearing fruit in terms of shortened length of stay. Whole range of work around automation, and we're going to do a piece of work with our people committee and our workforce colleagues to really look at where we can use automation to take pressure off some of the workforce gaps that we've heard, and some of the pressures in filling key posts. There's a real opportunity now with the capability Cheshire and Merseyside's got in automation to just go aggressively and look for where we can fill gaps in our workforce and drive efficiencies. So there's enormous amounts of work in flight. Just to give colleagues a view of where the goalposts have moved a little, or where we have some more information. So a lot of local context. The Liverpool Clinical Services Review is prompting us to think quite deeply around how we build a digital architecture to support that patient flow between organisations more seamlessly. We've been part of a national digital maturity assessment piece of work that's given us quite a detailed view of where all our provider organisations are in terms of the levelling up agenda and the digital maturity. So that's more intelligence to play into our reprioritisation. National strategies around primary care access recovery, some quite helpful targets in there, but as Naomi said, we mustn't miss the point of those targets in just deploying tech without the workforce and the business change pieces. Big piece of work around cyber security and some very clear expectations in the national strategy, which require our provider level response, an ICB level capability and a national capability all to work together. So I'll be coming back to this meeting with a detailed plan around that. And the context to all of this is pressures on the national funding. So we need to be creative around what we prioritise. And finally, just to add to the challenge, we've had 7 short-term digital priorities given to us this summer, all focused on secondary care and elective recovery, and they've all got really ambitious timelines. So without going through the whole list, we have to have a smart system control system in place by the 1st of December. We're on track to do that. We're just going through procurement now. We've got national funding for that, but that will give us our traffic control system across the system. Electronic bed management. 2 of our trusts have been selected as pilots to implement a new solution, again, adding pressure into the system. AI diagnostic support, national fund available. We're really taking advantage of that. There are 3, currently 4, potentially 4 specialisms within the diagnostics work that are actively looking to take funding to develop diagnostics tools to shorten the waiting list effectively for diagnostic results. I won't go through all the rest of the slides. I'll just highlight some of the sub-strategies that we're working on. So the original strategy is very high level of necessity, but to drill down and really understand what we need to do, we're developing sub-strategies which outline priorities in those themes. So we've done one for digital maternity, cybersecurity. We're working with our people college on a workforce strategy, and our digital clinical leads in primary care are working up a digital primary care strategy. That additional intelligence will allow us to prioritise further. So the ask really is to endorse our approach to a recalibration of the plan, and I propose to come back with a single plan and an associated governance that has all stakeholders in the system owning the moving parts to delivering that plan.
Thanks for summarising that, John. So, plan here for endorsement. Adam?
Yeah, thank you for that. And I've no problems with the plan itself. I suppose I have got a plea around terminology, because I think there's a few places we describe digital primary care when I think we mean digital general practice. Because there's certainly bits on the summary care record where the other elements of pharmacy care might tie into, but I don't think broadly we are thinking about all of primary care when we're talking about those schemes. I think we are purely talking about general practice an awful lot of the time.
So I think it's helpful to make the distinction at the time, isn't it? That strategy will encompass the broader primary care scope, and it was something we discussed in the medical directorate meeting yesterday. But absolutely take the point, and there are discrete pieces of work we need to do with pharmacy around interoperability, access to the records, shared records, etc. So that will be in that sub-strategy.
Brilliant. As we've spoken about, if we need any help coordinating that with all of the disciplines, you've got that through.
Perfect.
That's a good point. Anne?
One of the things that distinguishes us as an ICS is that we've got this most complicated landscape of different providers that you really don't see replicated anywhere else in the country. And, you know, it's that kind of urban concentration as well, where therefore what we get is patients bouncing between different providers, and also the way in which we deliver our specialist services also mean that that applies to the whole of Cheshire and Merseyside. So whilst that idea that we'd have standardisation of an EPR in Liverpool is, you know, it's a great aspiration and it would be a start, but it still doesn't kind of solve the problem for all the Cheshire and Merseyside. One of the things, and I've said this to you before, and perhaps I should remember what answer you gave me last time, but that shared care record thing just seems to be more important for Cheshire and Merseyside than it would be for other places, because that's the only repository of everything that's happened to a patient. And one of the risks in our system is, because we've got patients bouncing around all these different places, you never get the kind of full history unless you've got a shared care record. So, you know, it would seem to me that whilst the aspiration to have some shared EPR would always be really difficult to do, A, because of the cost and the time, and there's that many different providers, that would just take forever. But there's a kind of shortcut to it by if we had a shared care record, which are much easier to procure and implement and all that. But at least to be a repository somewhere of everything we need to know about that patient. So it just feels like that'd be, you know, like one of those pragmatic things to do that might be not the perfect solution, but would tick a lot of boxes as regards ensuring that we do the best we can do in order that we've got the full picture for the patient when we get them treated, especially as an emergency admission when they can't necessarily tell us stuff.
So completely agree with that, Anne. I did skip over a slide on shared record because of time. We've got, as you know, 4 different shared records. Our plan, which we're about to relaunch, takes us to a procurement in 18 months, but in the interim focuses on optimising and rolling out further what we've got, doing exactly what you described. I couldn't agree more. An EPR convergence solves some questions, but not the system-wide working, and is only in an acute setting anyway. So as a priority, that shared care record piece is really important. And we've got a call with, coincidentally, with St Helens Place colleagues around this that's just gone in the diary, just to accelerate some of the work that you described.
Thanks, John. Okay, I'm going to move us to the endorsement of this plan that's in front of us. People comfortable to do that? And final agenda item is scheme of delegation, reservation delegation. That's Claire.
Yep, so just very briefly, this is here for approval. It's already been through the final, it's already been through the audit committee who have ratified it, and it's coming here for board approval. It makes some changes to our scheme of reservation delegation to support further delegation down to place, and a number of anomalies identified in the first year of operation of our, and making our committees more effectively. So just asking for approval, please.
Yes, thank you, that's approved. And closing remarks, really good discussion, good meeting, thank you very much. Just wanted to highlight, we had received some questions from members of the public. We will make sure that the responses to those are on the website as soon as possible. Close the meeting at that time. I have run over, so I'm going to suggest, if that's okay, that we delay the AGM by 10 minutes to enable the room to be set up for the AGM. So members of the public, apologies for delaying the AGM 10 minutes, but I think it's important that we get it right, the room set up right. Thank you very much.